Okay, good morning. Can you guys hear my voice? Can you guys hear my voice? Welcome everyone to the 30th lecture of Dr. Hydri Step 1. Do I have a clear voice before I begin the lecture? Thank you so much for letting me know. Okay, hope you guys had a great weekend. Thank you so much for joining the 30th lecture of Dr. Hydri Step 1. Um, and hoping you guys had a very good weekend. Did you guys get to solve any UL questions? Okay, good. Just want to know just want to know a little bit about your weekends. How was it? Was it good? Was it bad? Did you guys use the weekend to get refreshed for this week? This week we are going to go a bit easier on the topics of first aid. Busy having exams. Okay, so busy having exams. Um, how about everyone else? Did you guys have a good weekend? Okay, good. That's very good to know. Okay, so the weekends are just as important as the weekdays. Okay, still cannot believe that it's already Monday and we are back. Although I'm really happy that we are doing the lectures, but that's that. Okay, that's very good. Okay, sport. Okay, so first and foremost, congratulations for finishing neurology. Okay, so we are all done with neurology, although we do have two topics that are left to discuss. Okay, we promised we would have discussed the CT scans and MRIs of the neurology, and we also promised on discussing. We also promised on discussing the table for the neurotransmitters, and we would be doing that too. Okay. Having said that, I was planning on moving on with first aid by starting psychiatry today, and after that, after the end of the lecture, or maybe tomorrow, I was thinking of starting the CT scan. So, is it okay? Because since we already spent around 2 weeks on neurology, I think it's better that we start a new topic instead of going to neurology. Just want to know some feedback from you guys. So what do you guys think? Psychiatry should be good since we already spent two close to around 14 days on neurology. Although it was really big, we planned on finishing it on 10 days, but that did not happen because of the huge, vast topics which neurology covers. So we do not only read through first aid, we also have to review and recall the entire text. So that's why it took time. But having said that, are you guys confident with neurology? Are you guys confident with the questions you might face from neurology after doing our lectures? Yes or no? Okay, perfect. That's perfect. So, after you guys did the neurology, when you guys did the question, did you guys come across questions which were common to our lectures? Okay, so can I get some examples of the questions which you guys faced that were common to our lectures? Maybe one or two examples from the student that would be helpful. Questions regarding neurology. Frontal lobe lesions, anti-epileptic drugs, okay, drug for absence seizures. Okay, so very basic standard questions. Okay, that's very good. Okay, you cannot hear me very well. Okay, can everyone hear me properly? Do I have a problem? Does anyone have a problem hearing my voice? Okay, so if you are having a problem, Dr. Ahmed, Dr. Omar Ahmed, if you're having a problem, please would you please try fixing the settings in your Zoom to see if there's anything wrong with the voice of the host, or there's an option for the volume of the host. Okay, so please try fixing that. Okay, you are welcome. Okay, good. So, would you guys be interested in doing a very short recapitulation of neurology to see where we stand? Everyone, to see where we stand, some of the high yield topics, so that if we have a new student for this group, so that they will have an idea. So basically, what we do is, what we do is in Dr. Hadi step one, it's a 4 to 4.5 hour lecture. The lectures are divided into three segments. The first part is the revision and recapitulation, in which we try to review and recap the previous lectures. After that, we move on with our regular tasks of the day. So basically, we try to focus on finishing at least 10 pages, depending on how easy or hard the topics are. We either try to get 10 pages or we stop at like 8 or 9. But our goal is to read through first aid and review, recall, memorize, and associate U-World questions with the first aid then and then. After that, in the last segment of our lecture, what we do is we do U-World questions and we try to solve offline U-World 5 to 10 questions every day associated with the topics discussed on the very day. Okay, so that's that. That's how our lectures usually go. Okay, so although we are going to start a new topic for today, that is psychiatry, just want to do a quick recap of neurology to see if everyone is standing on the if every one of us are on the same page on neurology or not. Okay, so just some basic questions here and there, nothing extraordinary. So the first question, so here we go. So we should start with the recapitulation. It's already 9:17. We will do the recapitulations for till 9:30, 9:40. Okay, and then we will start. Okay. So the first question is, what is the location of paramedian pontine reticular formation? The first question. Can I get some fast answers? Paramedian pontine reticular formation. The location is in the pons. Okay, so paramedian pontine. Okay, very good. Okay, what are the nerves that you expect to find in the cavernous sinus? What are the nerves, the cranial nerves that we expect to find in cavernous sinus? Okay, 3, 4, 5, 6. Very good. Okay, out of 3, 4, 5, 6, which nerve is more prone to get injured? 6. Very good. Okay, if you have a defect, okay, if you have a defect in the left upper quadrant of your visual field, bilateral defect of the left upper quadrant of the visual field, which is also known as pie in the sky, where is the actual lesion? In which structure is the lesion taking place? Very good. Okay. Okay, the next one is, okay, so we are just going to touch on some of the topics to see if we are on the same page. Okay, so very easy questions and fast and easy answers are expected. Okay, the next one is, if you have a Pancoast tumor, if you have a Pancoast tumor, what do you expect to find in your patients in regarding to the ophthalmoscopic findings of the patients? Horner syndrome. Okay, so by that, ptosis and meiosis. Okay, very good. Okay, good. Next one is Marcus gun pupil. Okay, so if I ask you about Marcus gun pupil or Marcus gun pupil, what is the Marcus gun pupil? How does the pupil look in Marcus gun? Does anyone have any idea about how the Marcus gun pupil looks? Okay, so if I shine the light into a normal eye, there will be constrictions of both eyes. But if one of the eyes have a problem, and I shine the eyes, and if I shine the light in the affected eye, will the opposite eye constrict or not constrict? Not constrict. Okay, so basically that's Marcus gun pupil. Okay, how about if I ask you about Ardrell Robertson pupil? Argyll Robertson pupil. Can you have accommodations in Argyll Robertson pupil? Yes, you can, but no reaction. Okay, very good. Okay, next one. Next one is if I tell you that during ophthalmoscope, you find you have a patient with findings of surrounding bony spicules in his eyes. Okay, bony spicules. What is the diagnosis? Very good. Okay, thank you so much for answering this so fast. Okay, this is supposed to be a difficult question, but the fact that you guys answered this so fast um, makes me realize if you guys have thought about the picture that we talked about as soon as I mentioned the bony spicules. Did that picture come to your mind? Okay, the picture came to your mind. Okay, good. Very good. And if you have a patient with increased intracranial pressure, okay, what do you expect to find in the ophthalmoscopy findings? If you have a patient with increased intracranial pressure, papilledema, very good. Okay. Next one is if you have a patient who comes to you with with an ophthalmoscopic findings of cotton wool exudates and exudation, what do you expect to find in that patient? Okay, very good. Hypertensive retinopathy. Okay. Next one. Next one is if you have a patient who comes to you with macular degeneration. Very easy and direct question. What is the problem? Age-related macular degeneration. If I have to ask you about what type of drugs will you prescribe to the wet type of macular degeneration, what is your answer? This is an advanced question. Okay. Okay, good. So no question is advanced for you guys. That's what it is. Okay, because the answer is anti-VEGF. VEGF. Very good. And would anyone be kind enough to tell me the name of anti-VEGF? Does anyone remember the name of any drug which has the properties of anti-VEGF? And the name of the drug is bevacizumab. Okay, bevacizumab. Okay, very good. Bevacizumab. Okay, good. Okay. If I ask you that you have a patient who has come to you with headache, tinnitus, vertigo, nausea, okay, and sensorineural hearing loss, what is your provisional diagnosis? Meniere's disease. Very good. Okay. If I tell you that you have a patient with Bell's palsy, okay, but the patient's, if you have a patient with Bell's palsy, but the patient's scalp is not involved. Is it an upper motor neuron facial nerve lesion or a lower motor facial nerve lesion? Very good. Okay. Okay. Not involved. It's upper motor. Okay. If I ask you that you have a patient who has come to you with staggering gait, ataxia, has a complication of diabetes mellitus, hypertrophic cardiomyopathy. Okay. The patient has Friedreich's ataxia. Very good. Okay. What is the repeat disorder? Fast answers, please. What is the what is the repeat disorder? GAA. Okay. Can anyone tell me the name of anyone tell me the name of the spinal columns which undergo degeneration in Friedreich's ataxia? Okay, good. Very good. Okay. Okay, good. Okay. Okay, good. So far you guys are answering very well. Okay, my next question is if you have a young patient who comes to you with asymmetric flaccid paralysis and fever, what is your provisional diagnosis? With fever and without fever. Asymmetric flaccid paralysis of the lower limbs. With fever is polio, and without fever, spinal muscular atrophy. Very good. Spinal muscular atrophy. Okay. Next one is if you have a patient who comes to you with combined upper and lower motor neuron lesion, what is your diagnosis? ALS. Okay. Next one is if you have a patient who comes to you with head trauma. Okay. Along with this, the patient has the patient has uh, mm, the patient has paralysis of the lower limbs. Okay, so my question is if you have a patient who comes to you with trauma to the head, along with that, the patient has paralysis of the lower limbs. Okay, along with this, the patient also has of some degree of some degree of urinary incontinence. Okay, what is the type of herniation that you might think the patient has? What is the type of herniation? Cingulate herniation. Very good. Okay, cingulate herniation. That is a very good answer. Okay, so basically, my question was if you have a patient who comes to you with trauma to the head, and along with this, the patient has paralysis of the lower limbs. Okay, so it's an ACA injury, and which type of herniations do we get ACA injury? And the answer is cingulate herniations. Very good. Okay, next one is if you have a patient who comes to you with decreased consciousness, respiratory depression. Okay, the patient is comatose after a trauma to the head. And if I have to ask you what type of herniations can you see in this patient, what is your answer? Tonsillar. Okay, cerebellar, cerebellar, tonsillar herniation. Okay, very good. Cerebellar, tonsillar herniation. So are we on the same page? Is everyone understanding the questions? Okay. Okay, so these questions, how does it seem on a scale of 1 to 10? 1 being the easiest, 10 being the hardest. What do you think the levels of these questions are to you guys? If 1 is the easiest and 10 is the hardest, how do you guys feel in answering these questions? Easy or hard? Okay, pretty easy. Should be around 3 or 4. Okay. Should be around 3 on 4, but these are actually pretty difficult questions. Okay, so to anyone else who has not studied neurology, to them these questions should be around 8 or 9. Okay, to you guys it's 3 or 4 or 5 or 6. Okay, so considering that's because you guys have understood the topic very well. Okay, so once again, thank you so much. And let's move on. Okay, the next things which I want to discuss with you guys are very quick. I just want to see if we remember the tumors of the brains or not. Okay. Okay, so these questions seem easy, but while solving U world, I make silly mistakes. Okay, so Dr. Hassan, the thing is, okay, so knowing the book is knowing the texts in the book is number one, and then number two is application of knowledge from the texts in the book, and that requires practice. Okay, so first of all, if you have the text in the book completely understood, okay, then you will realize that applying the knowledge while you are solving your UWorld question, okay, that is something which you have to excel by solving a lot of questions. Okay, so that requires a lot of practice. So what I would ask you to do is to just hang in there. Okay, have patience and really trust yourself, trust your knowledge, and always trust your answers. Okay, even if you make the mistake, make sure you make the mistake confidently. Okay, so having said that, the reason I said that is because if you make a mistake confidently, then you would want to know why you made that mistake, and then when you learn from that, okay, then what would happen is the next time you face a question, which is similar to the questions you made a mistake with in the past, okay, you will not make the same mistake again. So that's the thing. Okay, so that requires a lot of practice, and I know each and every one of you will excel if you keep on doing the UL questions like how we ask you to. Okay, but in terms of remembering the text from first state, that's a different level of confidence by itself. Okay, so if you are confident that you know all the text in first state, you will feel extremely confident when you solve the UL questions. Okay, so just hang in there. You will do really well. Okay, and hopefully you will stop making the silly mistakes which you're talking about. Okay. Can anyone tell me the mnemonics for the adult primary brain tumors? If you have a patient who comes to you who is an adult with the sign symptoms of nausea, early morning headaches, vomiting, seizures, okay, neurological deficits, okay, go away or get out. Was it get out or go away? Get out. Okay, get out. Please, my head hurts. With that, we have glioblastoma, oligodendroglioma, pituitary adenoma, meningioma, that right, hemangioblastoma, and schwannoma. Okay, of course. So we have a question from Dr. Ahmed. Can I know your plan for solving the UWorld questions? Okay. So okay. So the plans for solving the UWorld questions. What we do is during our lectures we read through first aid. Okay, after we read through first aid, we try to solve UWorld questions, around 5 to 10 questions a day from the offline UWorld. Okay, which is related to the topic we discuss on the very day. Okay, after that, what we do is, what we expect you guys to do is, after you're done reading first aid with us, okay, we expect you guys to solve the UWorld questions. So every day we expect you guys to solve around 30 to 40 questions. And if you guys can stick to your 30 to 40 questions every day, then you guys can finish your UWorld. If it's the first time for you, you guys can finish UWorld in 3 to 3.5 months. Okay, and basically what you need is, you have to solve UWorld properly, at least for the first time, regardless of your percentage in UWorld. And then for the second time, either you can do a full reset of the UWorld, or you can do the questions which you have gotten wrong for the first pass. Okay, either way. So the very important thing is you stick to your 30 to 40 questions every day. And then after that, what we expect you guys to do is, we expect you guys to do 1 hour of pathoma. That's another thing. Okay, so that's what we expect you guys to do. So that's that. Okay, having said that, have you received our lesson schedule, Dr. Ahmed? Yes, hello. So can you guys hear my voice? Okay, I apologize. I just had a minor just had to take a very important phone call from the hospital. Okay. So can I get the questions? Okay, so let's answer some of the questions. So hope I answered the question from Dr. Ahmed, which was regarding the URL solvings. Okay, so that's what we do. You guys have not received the lesson schedule for this week, and we would be sending you the lesson schedule by today. Okay, that's what we would be doing. And okay, that's that. Having said that, Dr. Ahmed, if you have any other further questions, please send us an email, okay, to ferdin.hydri@gmail.com. And at the same time, I know, I mean, we know that a lot of you are having some difficulties in clearing your transactions for this week. Okay, so what we do is we usually let you guys, we usually let everyone do the classes from Monday onwards, especially for the students who have not asked for any extensions. Okay, so we do that. And if you ask for extensions, we do not mind letting you do classes for as long as you want. In the meantime, if you need time to clear your transactions, we provide as much time as you need. So that's the issue. So the thing is, if you guys still need extensions to clear your transactions, please let us know. That's all you have to do. If you can only let us know, that would allow us to know which students are interested to continue and who are not. So that's that. Okay. Okay, so the next question is from Dr. Hassan. Okay, her question is, I solved 40 questions, but could review explanations of upload 26. How can I increase my speed? This is the first time I'm solving 40 questions before I should do 10 to 15. Okay, good. Okay, so we have a question. We have a question. The question is, so we have a, so this, okay, so Dr. Hassan is solving 40 questions per day. Yeah, but she can only do 26 explanations. Okay, good. So the thing is, what I would ask you to do is I would ask you that instead of solving 40 questions at once, okay, instead of solving 40 questions at once, if you can only do explanations for 26, then stick to doing 26 questions a day. Okay, the reason is when you are solving UWorld, always remember, it's not about the quantity of the questions which you solve. It's about the quality at which you solve the questions. It's about the quality at which you solve the questions. I apologize. Is it possible to get another 2 minutes, please? I'm really sorry. Just one more important phone call, and then we're done. Okay. Okay, all right. Okay, my apologies. I'm sorry. Um, just a little bit over. We're just having a little bit of problems regarding my father's surgery, and I just have to answer a lot of phone calls, and I apologize for that. Okay, so having said that, where was I in terms of? Okay, so can everyone hear my voice once again? I promise there will be no more interruptions. Okay, okay, perfect. So as I was saying, I was talking about the solving UWorld questions. And so the thing about solving UWorld questions are when you solve a UWorld question, it's always about the quality of the questions with which you solve, which with which you solve. It's not about the quantity of the question. Okay, you can easily do 100, 200 questions a day, but you will not be able to review 100, 200 questions. So it's better to do the amount of questions which you can review. What would happen is over time, let's say you do 26 questions today, over time, you will learn how to review the questions faster. Okay, and what will eventually happen is your quantity will increase. So let's say you are doing 26 questions today, and let's say you now have the skill to do the reviews very fast because you know exactly what to look out for and what not to look out for when you do the proper review. I'm sure a lot of you guys who have been solving questions for a long time, you guys know exactly what I'm talking about. That although everything in the URL explanation is absolutely important, but then there are still some things in with which you can just look at the explanations really quick, and then you exactly understand what you need to know and what you do not need to know. So once you figure that out, what would happen is your quantity of the questions will eventually increase. So my advice to Dr. Hassan, who is having a difficulty in solving 40 questions every day, is to not solve 40 questions every day and stick to solving 26 questions with which you can do the proper explanations. And eventually what would happen is your number of questions will increase. Okay, so that's the best advice I can give you. Okay, does anyone have any other questions before we move on? It's 9:45 already, and I would like to move on with psychiatry. Next question. Okay. Um, okay, doctor, can you prepare a high yield question summary on the pharmacology of CNS? Okay. Okay. So you okay. So what we can do is so the thing is we did not I mean we spent as much time needed for the pharma section of CNS as much as possible. Okay. But if you guys need another revision on pharma, what we can do is we can set up a date and we can properly do a revision. The way we can do this is Dr. Naoud is correct. That is, CNS pharma is actually pretty important. Okay, so if anyone feels the need to do a proper revision, what they can do is they can read the CNS Pharma at home. And after you guys read the CNS Pharma at home, we can do a 10-minute or 15 minutes review of the CNS Pharma. And that would establish more confidence in the whole topic. So that's what we can do. Okay, so we can set up a date for a proper revision of the CNS Pharma. Hopefully it can be tomorrow if you guys are up for it. So that's that. Okay. Okay, next one. Do you have the brain tumor lecture recording? Yes, I do have we do have the brain tumor lecture recording. Okay, so we are, I suppose we send out the lecture recordings to you guys via email. Okay, so you guys should have the lecture recordings over there. If you still do not have the recordings, we will send it to you. Okay, any other question before we move on to our today's topic? Do we have any other question? Okay, perfect. Okay. Okay, if you did not receive lecture 19, we apologize. We will try to send it to you guys. We will try to send it to you today. Okay, we will try to send it to you today. And I know that we keep on saying that we will send you the lectures, but a lot of you do not receive the lectures. Okay, but we try to just try to understand that we get a lot of requests from a lot of students about about a lot of lectures. So we try to meet everyone's requests, and at times we get a bit slow in terms of answering our emails, but eventually we do. So hopefully we will. Okay, and we will try to also upload it on Google Drive. That's not a problem. Okay. Okay, of course, I can send it to you, Dr. Ahmed. Okay, so please send me an email regarding which lectures you need, and we will try to keep up with your request. Okay, everyone. Okay, just send us an email about the lectures you guys need, and we will try to keep up with your request. Any other question before we begin? It's 9:48. Okay. Okay. So if anyone has any other question, please keep it in your mind. And what we would do is when we have a proper timing for the question answer segments, then we will try to answer your questions. Okay, for now it's 9:48, and we would like to start. Having said that, from our recapitulation and review section of today's lecture, what I believe is you guys have understood the neurology very well. Okay, and we will set up a date for neuropharmacology review and recapitulation. That is tomorrow. So I need you guys to review the CNS pharma today, so that tomorrow morning we can start our first. The first thing in the morning we can do is we can do our neuropharma review and recap to see if we have understood everything. Okay, so that's that. So remember to do your review and recapitulations for the neuropharmacology section today. And tomorrow we will discuss everything regarding the neuropharmacology as asked by Dr. Naud. Okay, so that's a very good advice. Okay, good. So having said that, let's start with our today's topic. And for today's topic, we will start with psychiatry. Okay, psychiatry is an extremely high yield topic for USMLE Step One, and a lot of students will find that a lot of pathologies in psychiatry are very new because they are not very widely talked about in the bachelor's of medicine and bachelor's of surgery program from which we are all from. I mean, from which most of us are from. Okay, so having said that, okay, let's start with our psychiatry, and let me just share the page. One second. Okay. Okay. So can you guys see my page, my screen? Can everyone see my screen? Okay, good. So during this whole lecture of psychiatry, what I would be doing is I would be using a lot of mnemonics, a lot of stories here and there. So I need you guys to pay a little bit more attention so that you guys can grasp everything. Okay, so let's begin. It's 9:50 as of right now, and hopefully we will try to finish 10 pages of psychiatry today and see what's up. Okay, so the first thing is the first section of psychiatry is psychology. Okay, so psychology is not the same as psychiatry. Okay, psychiatry is a medical degree, psychology is a paramedical degree. Okay, so psychologies have different types of conditions which we have to associate ourselves with. Okay, and to the students who are solving questions regularly, okay, does anyone know how important ego defenses are? From not important to very important, how important are ego defenses? Ego defenses, how important is ego defenses? Very important. That is true. That is absolutely important, ego defenses, and we would be talking about this today. Okay, and you guys will receive at least one or two questions from ego defenses in each and every block of your USMLE Step 1. That's how important it is. Okay, having said that, before we move on to the big topic, ego defenses, the first thing that we will talk about today, and the first thing with which we will start our lecture, is classical conditioning. Okay, so first of all, what is classical conditioning? Let's read the text first and let's see if we can try to understand. The best part about psychiatry is you don't have to memorize, review anything. Okay, you don't have to memorize anything, you don't have to keep in mind anything, you just have to understand what the disease is and what they're asking you to do. So that's the thing. So just keep your attention to the text and you guys should be fine. Okay, the first thing is classical conditioning. So what is classical conditioning? It's basically a learning in which a natural response is elicited by a conditioned learned or stimulus that previously was presented in conjunction with an unconditioned stimulus such as food. Okay, so let's break this down. Okay, so what is classical conditioning? First of all, if we have, let's say that if you have a young child, okay, we know that we have a lot of parents over here in our we have a lot of parents over here who are students in Dr. Hadi Step 1. Okay, so if you have a young child, okay, if you want to discipline your child, let's say that the child does something bad. Okay, let's say the child disobeys you. Okay, do you try to provide a reward to the child after the child disobeys you? Yes or no? No. So you do not try to reward a behavior by your child where he or she disobeys you. Okay, so what you try to do is you try to do the opposite. Okay, you do not provide a reward, you do the opposite of a reward. You do a small punishment. I mean, by that I mean that, it's not a, it's not obviously a violent punishment. Okay, so what you try to do is maybe you try to scold the child, or maybe you try to discipline the child by taking away something. Let's say the child has a let's say that the child has a toy with which he or she plays, and then if the child disobeys you, you take away the toy. Okay, so that's the type of punishment. Next thing is, let's say the child does something good. Okay, let's say that the child obeys you and does exactly what you say. Now, do you provide the child with a reward or not with a reward? Yes or no? Yeah, so now you provide the child with a reward. So what happens is, when the child, okay, when the child gets provided with the reward, does the child do the same thing again? I mean, does the child do the same action again? Yes or no? Yes, because the child is looking forward to the same reaction. The child is looking forward to the same reaction from you after he gets rewarded or she gets rewarded. So he or she will do the same action again. But if the child is punished for an action, will the child repeat that action? Yes or no? No, the child will not repeat an action. So that's what it is. Okay. Okay, so what happens is, out of all of this, you have two types of responses. You have a voluntary response, and then you have an involuntary response. Okay, so we have a voluntary response, and then we have an involuntary response. So let's say the involuntary response is, there is a certain experiment which was done. I'm not sure if you guys are well acquainted with this experiment. It was known as Pavlov's classical experiment with dogs. Pavlov's classical experiment with dogs. Okay, so what Pavlov basically did was, that uh, every time the Pavlov would provide the Pavlov was a researcher basically. So what he did was, every time he would provide the dog with food, he would ring a bell. Okay, so every time Pavlov provided food to a dog, he would ring a bell. And after, what happened was, there were times when he did not provide the dog with the food, but he still rang the bell. So what that did was, okay, what that did was, instead of what that did was, it instantly resulted in the salivations of dogs. Okay, so that's an involuntary response. Okay, so let's say that this is the okay so let's say that okay let's say that this is the weird looking dog, okay, over here. Okay, looks like a duck, but it's a dog. Okay, and then this is our friend Pavlov. Okay, this is our friend Pavlov with the bell. Okay, okay, the Pavlov is shaking the bell, and then you have the food over here. Okay, so every time the dog comes and eats the food, Pavlov would shake the bell. Okay, so that's an experiment which he's doing. next time what he did was Next time what he did was, okay, so you have this dog over here. Okay, and next time, instead of instead of giving the food, Pavlov, all he did was, he rang the bell. He rang the bell. Okay, so next thing what happened was, after he rang the bell after he rang the bell, the dog thought that Pavlov gave the dog food, but Pavlov did not provide any food to the dog. So this resulted in salivation. Okay, this resulted in salivation because the dog thought that the dog would get the food. So this is an involuntary response. Have you guys understood this example? Yes or no? Yes or no? Okay, so it's broken down into very, very easy text. So that is what basically what this is. So this is known as classical conditioning. This involuntary response is known as classical conditioning. The same way we also try to train our pets. If we have any dog or cat in the house, do we have any pet owner in the group today? Do we have any pet owner in the group today who owns a dog or a cat? Okay, only one? Okay, good, very good. Okay, the golden retriever. Okay, brilliant. Okay, okay, good. So when you guys try to train your pets to go to the bathroom or to go to a certain place where they try to defecate or urinate, okay, that's the training which you guys put in for your pets in order for them to go to certain places to complete their urinations and defecations. That is known as classical conditioning, more or less. Okay, so the next time the dog will not go to the place where they're not allowed to go. Okay, so that is classical conditioning. So classical conditioning, once again, is it an involuntary or a voluntary response? Fast answers, please. Is classical conditioning an involuntary or voluntary response? Okay, it's an involuntary response. So please, the only thing that you have to underline from all this is this one over here. So very easy to understand. Okay, so it's an involuntary response. So please put a star beside your involuntary response. Okay, next one. Next one is operant conditioning. Next one is operant conditioning. So what is operant conditioning? Operant conditioning was our example for the young child, the mother with the young child who provided the punishment or the reward. Okay, so that is operant conditioning. Okay, so is operant conditioning a voluntary response or an involuntary response? Voluntary response, very good. So please underline the voluntary response part to in regards to operant conditioning. Okay, so that's that. Okay, so next time you guys receive a question and they will try to confuse you whether you know whether you can properly differentiate between classical conditioning and operant conditioning. Okay, so you guys have to keep your mind straight about whether the response is a voluntary response or whether it's an involuntary response. Okay, next one. In operant conditioning, you have these segments over here. First of all, we already understood what operant conditioning is. It's basically a learning in which an action is elicited because it produces a punishment or a reward. That is the example we use for the child. Okay, if he disobeys you, he does not get the toy. If he obeys you, he gets the toy, and then he keeps on doing the same action, which resulted in a reward. Okay, so that's what it is. Okay, so next one is reinforcement. Reinforcement is basically what happens is the targeted response is followed by desired reward or removal of the aversive stimulus. Okay, so so if you keep on giving the child a toy every time he does a good deed, does the child keep on doing the good deed? Yes or no? Yes or no? Okay, that's what it is. So that is known as reinforcement. So what you do is you try to provide the reward over and over again, and the child keeps on increasing that action. Either you can do that, or what you can do is you can also take away the negative, or I mean, you can take away the negative. I mean, you can take away the punishment. The child knows that if the child does this action, then the child will not get punished. Okay, so the child will also keep on doing the same action over and over again, except that for this time, the child will do it to not receive the punishment. So that is also a type of reinforcement. Have we understood reinforcement? Yes or no? Have we understood reinforcement? Yes or no? So repeated reward or a version of the stimulus. Okay, repeated reward or a version of the stimulus. So basically, if you're trying to test yourself, once again, if you're trying to test yourself whether you have understood the text or not, okay, the questions will come from this side. The answers are usually the terms, whether you know the terms or not. So which side do you cover your text with? Let's say we have A, we have B, and now you want to see whether you have understood the text. Which side of the book do you want to cover with your hands to see whether you understand or not? Fast hands, please. No. Yes. Oh, good. A. Good. Very good. So what you're supposed to do is you're supposed to cover this part with your hand. Okay. What we usually do is we cover this part with our hand, and then we try to see if we know what reinforcement is. That's not the positive way to go with this. The positive way to go with this is you have to cover this part with your hand and then read this part and then see whether you remember the term. Okay, reinforcement, because USMLE step 1 will test your knowledge about the terms. Okay, whether you know the terms of psychology or not. Okay, next one is punishment. Punishment is basically what's happening is punishment is the repeated application of the stimulus or aversive stimulus, okay, or removal of the desired reward or removal of the desired reward. What happens is, if a child, once again, let's say the child disobeys you, okay, let's say that the child disobeys you, okay, and there are two things which you can do. Either you can take away the reward, okay, either you can stop giving the child the toy, or you can, let's say, provide a punishment. Let's say the punishment for this child is for, like, let's say the usual punishments that parents in America try for their children is timeouts. Timeouts are basically times when the child is devoid of all toys. Then let's say the child is using is using a cell phone or anything, and the parents take away those things. Okay, so that's basically a timeout. It's very different from it's very different from the punishments which we used to receive when we were child. Okay, so we are from, I mean, I personally am from a third world country. Okay, so what my parents would do, I mean, my mom would do is beat the shit out of me. Okay, so that's what it is. I'm not sure if a lot of you got okay. I'm not sure if a lot of you uh got beaten up by their parents. Okay, so I'm glad my mom did that. Okay, so that's what it is. Okay, but in this country it's impossible. Okay, in this country you are never supposed to lay your hand on a child. So what the parents usually do is they try to ground their children. Okay, so if you try to ground your child, okay, if you try to ground your child, will the child do the same thing again? Yes or no? No, the child will not do the same thing again. Okay, so that's the punishment. And either that, or what you do is you just take away the reward, and that's the same thing. So that is basically punishment. Okay, so that is basically punishment. So punishment is either you repeat the punishment or you take away the reward. So that's what it is. Okay, next one is extinction. Okay, next one is extinction. Extinction is basically discontinuation of reinforcement, eventually eliminates the behavior. Okay, so basically what happens is you want to enforce a behavior on your child. Once again, okay, the same example for the child. If you want to enforce a behavior on your child based on the fact, okay, based on the fact, let's say that it's a negative behavior. Okay, let's say that the child is very let's say the child likes fighting other child. Okay, I mean you have children who likes to fight other children, and you want to teach your children that it's not okay to fight other people. So what you do is you either repeat the punishment over and over again, or you take away the reward for a long period of time, and eventually what will happen is there will be extinction of that negative behavior. Okay, there will be extinction of that negative behavior, and that is known as extinction. Okay, are we clear on the five terms which we have just read? Classical conditioning, operant conditioning, reinforcement, punishment, and extinction. Are we clear on these terms? Yes or no? Are we all clear on these terms? Okay. 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 So, okay, I will explain again. First of all, let's do a small recap to see if any of us remember the terms which we have just talked about. Okay, if you want to enforce a behavior on a person or on an animal, and it's an involuntary response which you are looking out for, what is the term? Involuntary response. Classical conditioning. Very good. If it's a voluntary response which you want to increase or decrease, what is the conditioning that you would do? Operant conditioning. Very good. So involuntary is classical and voluntary is operant. Next one is if you want to enforce a behavior and you keep on doing the positive action over and over again, and the child learns a new behavior that is a positive behavior. Let's say the child is kind to everyone because you taught the child to be kind to one by giving the child a toy every time the child is kind to another child. What is the term used for this one? Reinforcement. Very good. That you want to reinforce the behavior. Very good. Next one is if you want to remove a negative behavior from a child, and you take away the child's toy every time the child does something negative. Okay. So what is the term used for this type of conditioning? It's punishment. Very good. Punishment. And then what happens is over time, every time the child does something bad, you take away the child's toy, and you keep on taking it away until and unless the child stops uh stops I mean the child stops being rude to other people. Okay, what is this term used for the discontinuation of the negative behavior by the child? Discontinuation of the negative behavior of the child. This is known as extinction. Okay, very good. So have we all understood the five things? Classical conditioning, operant conditioning, reinforcement, punishment, and extinction. Yes or no? Okay, good. Okay, Okay, Dr. Ahmed, if you have any question, please keep it in your mind. Okay, and we will answer it for you. Okay, and we will move on. Yes, the chart is very high yield. Okay, is the chart high yield? Yes, the chart is high yield, and we will go for the chart. Okay, basically the chart is if you want to increase a behavior, you add a stimulus. Okay, you add, so either you can add a stimulus or you can remove or you can remove a stimulus. So what would happen is if you want to increase a behavior, you want to give a positive stimulus. So let's say increase behavior. Okay, the child is kind. Okay, so kindness or being rude to other people. Okay, being rude to other people. So if obviously you want to increase the behavior of the child in which the child is kind to other people, so what you do is if you want to increase the behavior, you give a positive you give a positive stimulus. Let's say every time the child is kind to someone, you give the child a toy. You give the child a toy. That's a positive reinforcement. Or if you want to increase the behavior, what you can do is every time the child is kind to someone, you tell the child that the child will not be grounded. The child will not be punished. Okay. If okay, so either of these two stimulus will increase the behavior. Okay, that's the chart. I mean, that's how their behaviors are increased. The next one is if you want to decrease a behavior, let's say every time the child is rude to someone. Okay, you ground the child. Okay, you ground the child or you take the child for a timeout. Okay, so that's a positive punishment. That's that. That's that. And if you want to decrease a behavior, what you do is you can also go for a negative punishment. Okay, what you what would like also go for is a negative punishment. Let's say that instead of grounding the child, you tell the child that the next time you do this, I will not give you any toy. Okay, so that's a negative punishment, meaning that you are asking the child, you are telling the child that you will not give any reward for these type of behaviors. These type of behaviors will not get rewarded, so the child will stop the behavior. So that's what it is. Okay, and is this chart high yield for USMLE step one? Not that much. Okay, you will not receive a lot of questions from this. The questions which you will get for USMLE step one from all of this are you they will try to test you whether you know the knowledges. I mean, whether you're well acquainted with the terms classical conditioning, operant conditioning, reinforcement, punishment, and extinction. Are we clear? Okay. Questions? Okay, so extinction. Okay, extinction, explain again. Okay, I will explain extinction again. Okay. Okay, so what is extinction? So let's say your child is being rude to someone for a long period of time. Okay, your child is being rude to someone for a long period of time. And every time the child is rude to someone, you provide the child with a punishment. You provide the child with a punishment. Your punishment is you ground your children. You take away their toys, their phones, everything. You take away everything from them. And over time, if you keep on doing it, will your child be rude to other people in the future? Yes or no? Fast answers, please. Yes or no? Okay, no, your child will not be rude to other people in the future if you take away their toys. Your child will not be rude to other people in the future if you take away their toys. So have you eliminated that behavior forever? Yes or no? Yes or no? Yes, you have eliminated that negative behavior about your child, okay, forever. And that is known as extinction. Okay, that is known as extinction. Okay, this elimination of behavior after you have, okay, yes, it's like punishment for a long time. Yes, that is very well said. I mean, that's what it is. And over time, what happens is the right, the extension is the punishment for a long time and it eliminates the offending behavior, more or less. Okay, so that's what it is. Okay, positive. Okay, so positive punishment. So what is positive punishment? Positive punishment is basically when the child does something wrong. Okay, you actively perform a punishment for the child. I mean, you actively give the child a punishment, meaning that you actively decide to take away the child's toy. Okay, you take away the child's toy. That is punishment. Okay. Extinction is opposite. Extinction is not opposite. Extinction is basically you provide the punishment for so long that your child stops doing that action, or you provide, or you provide a positive reward for so long that the child does an action, but in most cases, it's elimination of a behavior. You want to eliminate that negative behavior, so you take away the child's toy for good. Are we clear, Dr. Iman, on extinction? Yes or no? You are not clear. What is your question about extinction, please? Can I please help you understand your confusion on extinction? Okay, so let's clear the confusions one by one. Okay, so Dr. Iman, would you be kind enough to unmute yourself and ask me what your confusion is, and I will answer it
Uh,
for you.
yes.
Okay.
Yeah, I thought when you take the reward
Mm-hmm.
for a long time, the bad behavior will come again because
Mm-hmm.
it's a discontinuation of reinforcement eliminate
Mm-hmm.
behavior. Like
Mm-hmm.
if he keep to ring the bell for a long time and he didn't bring the food for many time, the
Mm-hmm.
dog will stop salivation.
Mm-hmm.
Yeah, I thought this is extension.
Okay, good question. Okay, first of all, in order for me to answer this, first of all, let's talk about reinforcement at first. What is reinforcement? Reinforcement is you want to increase a behavior by either providing punishment, I mean, by either providing reward or taking away the punishment. Are we clear on that? Have you understood reinforcement? Dr. Iman, have you understood reinforcement? Yes. Okay, good. So next thing is if it's a positive reinforcement or there's a negative reinforcement. Positive reinforcement is providing the reward. Negative reinforcement is removing the stimulus. Okay. So the thing is, if you want to eliminate someone's negative behavior, do you want to provide more rewards or do you want to provide punishment? Fast answers, please. Fast answers, please. If you want, okay, so you want to provide, if you want to eliminate a negative behavior, every time the child does anything bad, you want to take away the reward or you want to provide the punishment. So over time, what happens is you keep on doing it for over and over again. If will the child do something you do not like or do something you do like? What is your answer? According to you as a parent, if you want to make your child do something, do like exactly. So either what happens is there will be extinction of a behavior or the child will be reinforced with a behavior, with a new behavior. Have we understood now? There can be two things. The child can either get reinforced with the behavior or the child will have extinction of the behavior. Okay, so good behavior, reinforcement; bad behavior, extinction. Okay, have we understood now? Okay, perfect, perfect. Okay, good. So can we move on to the next part of the, can we move on to the next one? Okay, the next thing that we will talk about is transference and counter transference. If you guys have any questions, please keep it to yourself. We will answer it after the end of the lecture, okay? The next one is transference and counter transference. So what is transference and counter transference? Okay, so transference is basically the patient projects their feelings about formative or other important persons onto the physician. Okay, so what happens is, what is transference? Basically, the patient will transfer. Okay, so what I will do is I will write two things. Okay, write it down. Number one is PT. The second one is CD. Okay, if you guys remember PT and CD, then your questions regarding transference and counter transference will be really easy. And let me explain what PT is. PT is patient transference, and CD is counter transference by doctors. Okay, so what is PT? PT is patients. Okay, PT is patient transference. Okay, transference are done by patients. Okay, what is the transference? Transference is basically, let's say that growing up, a patient does not have a father. Okay, growing up, the patient does not have a father. Now the patient goes to someone, let's say a psychiatrist, and then the psychiatrist guides the patient, motivates the patient, and does everything more or less that a father does, except the fact that the psychiatrist is not the patient's father. But the fact is, every time the psychiatrist acts the way he or she acts, the patient sees the psychiatrist as his or her father. Okay, this type of feeling is known as transference. Have you understood transference? Yes or no? Okay, good. Easy to understand. Next thing is, as a physician, let's say that the next time you see a patient, okay, okay, let's say that you have a younger sibling. Okay, let's say that any one of you guys. Okay, how many of you guys have a younger sibling? Do we have any students over here with a young sibling? Okay, good. That's very good. Okay, so what happens is next time, let's say you come across, let's say you have a young sibling who is a young boy. Okay, who is a young boy. So the next time you go to your clinic, okay, you come across a patient who reminds you of your young sibling so much that you transfer your feelings about your young sibling into the patient. Basically, the doctor will project the feeling, okay, about his or her young sibling, for example, onto the patient. Okay, the doctor will project their feeling. Okay, let's say you start this type of feelings usually results in treatment bias. Okay, these type of feelings usually results in treatment bias. Okay, how does it result in treatment bias? Let's say that now, after you see this young patient as your young sibling, okay, and you're counter transferring all your emotions and feelings into this patient, now you will spend more time with the patient, more than you will with any other patient, or you will provide more care to this patient compared to all the other patients. And this is an example of a treatment bias, because all patients should receive the same type of care regardless of who or what they are. Okay, so your treatment should be the same for everyone. But let's say you are counter transferring your feelings about your patients and about your young sibling into the patient, then this is a counter transference. Have you understood transference and counter transference? Okay. Yes or no? Okay. So basically, try to remember the next time they try to confuse you with transference and counter transference, try to look out for who the question is talking about. If the question is talking about a patient transferring their feelings to their doctors, this is transference. Okay. Next thing is, if you have a doctor who has feelings, let's say the doctor sees the patient as a young sibling, they are talking about counter transference. Okay. So PT and CD. PT for patients are transferring, CD for counter transference for doctors. Okay. Have we understood this? Should we move on? Okay. Okay. Very, very well. Okay, good. Next one. Now we will start with our ego defenses. Now we will start with our ego defenses. Okay, and we will talk about one by one every ego defenses that we have over here. Okay, that we have over here, and this is extremely important for us to understand, because a lot of questions will come from this table by itself. Okay, having said that once again, okay, questions. Where will the questions come from? The questions will come from over here. Okay, the questions will come from over here. Examples, or the questions will never come as a description. They will never try to describe a defense. This is only for your understanding. Okay, then again, you do not have to memorize or review the whole thing. You just have to understand what these things are, and that should be good. And your answers are about your knowledge regarding the terms of the immature defenses, and whether you can differentiate one term from another term. That is how you will be tested in your USMLE step 1. Okay, so if you have to test yourself, okay, cover this part with your hand and read the example and see whether you can recall the name of the defenses. Now, ego defenses. Ego defenses are basically thoughts and behaviors which are used to resolve conflict and feelings. And basically, what ego defenses are, there are two types of ego defenses. One is an immature defense, another one is a mature defense. Okay, so immature defenses are your psychological problems. Immature defenses, so these are all immature things. These are not expected from an adult. These type of behaviors, or these type of immature responses to any feeling or actions are not expected from an adult. Okay, so these are immature defenses. These are not supposed to happen in adults. If it does happen, then the adult could be classified as a psychologically as a as a patient who is prone to get treated for a psychological condition. Let's say for these type of problems, they could get a CBT, okay, like behavioral training. So that's what they need, and those are usually provided by psychologists, okay, less by psychiatrists, okay. And these are the mature defenses, okay. These are how adults should act. So in mature defenses, you have sublimation, altruism, suppression, and humor, and we will talk about this in details, obviously, okay. So broadly categorized, the ego defenses can be categorized into immature defenses and mature defenses, okay. So we will talk about each and every one of this, starting from acting out, okay. So the first thing is, okay, so the first thing is, you have, let's say we are talking about a patient, okay. Let's say that we are talking about a patient. This patient, what happens is, okay, um let's say that this patient, what happens is, um, uh, let's say that you make this patient makes an appointment, okay. So first of all, what we can do is, let's read the thing, okay. This will be better. So acting out, what is acting out? This is basically a description in which this says that there's a subconsciously coping with the stressors or emotional conflict using actions rather than reflections or feelings, okay. So what's happening is, let's say your patient is mad at you, okay. Let's say that your patient does not like you, okay. Let's say that your patient does not like you. Now the next time, if you make an appointment with the patient, okay, the patient, instead of um, using actions, the patient cancels the appointment without letting you know, okay. So let's say you make an appointment with patient A, okay, and the patient A does not like you, okay. And what happens is, the patient A um, basically cancels the appointment without even telling you. Okay. So is that an immature defense or a mature defense? How would a mature person act? The mature person will call the physician and explain the physician what the issue is. Okay. Will tell the physician that this is something about you which I do not like, and I will not come to your appointment. And that is a mature way of dealing with things. The immature way is acting out. Acting out is basically being just telling the just not showing up for the appointment, okay. So that's basically an immature defense. That's one example of an immature defense. Next one is, let's say if you have a patient who is angry with you, and what happens is, the patient starts shouting at you in your clinic. The patient starts shouting at you in your clinic. So the patient is basically acting out on you. The patient is basically, maybe the patient is not happy with you or with the treatment which you propose. So the patient is acting out. Now the patient is shouting at you. So this is an example of acting out. Have you understood acting out? Have you understood acting out? Okay. So unhappy patients not dealing with the thing in a matured manner, and now the patient is acting out. Okay. So that's that. Okay. So let's move on to the next one. Okay. Then the next one is denial. Okay, so what is denial? Okay, denial is pretty easy to understand. So denial is pretty easy to understand. Okay. So what happens is, let's say that you have a patient, okay. Let's say that you are an oncologist, okay. Let's say that you are an oncologist and you have a patient, and you tell the patient that the patient has been diagnosed with a life threatening increased mortality related cancer, okay. So let's say the patient has a stage 4 pancreatic cancer with a very bad prognosis. The prognosis is not good at all. Okay. Okay. So what happens is, this patient, instead of staying home and resting, this patient plans out an entire day of work. The patient does not want to agree. The patient will needs rest. Okay. The patient is in full denial of the treatment that the patient needs, that requires recovery, that requires proper resting after chemotherapy. And let's say after chemotherapy, the patient goes to work. Okay. The patient is not following the doctor's advice. Okay. And then the patient is not aware of the fact that the patient has pancreatic cancer. The patient is denying that. Okay. So this type of defenses is known as immature defenses. The mature action would be the patient actually agreeing with the fact that the patient has the cancer, and the patient staying home and following the doctor's advice. So that is the mature action. And immature action is being in denial about your cancer, for example, and then not doing what the doctor asked you to do. So what you do is, instead of staying home, you go to work and do everything against the doctor's advice. This is known as denial. Okay. Have we understood denial? Yes or no? Okay, good. Okay. Next one is, okay, very good. So we are done with acting out. We are done with acting out. We are done with denial. Okay, next one is displacement. Displacement is very important. Okay. What is displacement? Okay. So let's say that we have a man. Okay, we have a man who goes to work. Okay, so we have a man, he's a father and he's a husband and he goes to work. Okay, he goes to work and he gets shouted on by his boss. Okay, so he gets shouted on by his boss. Okay, and then when he comes back home, okay, okay, so first and foremost, if the man is shouted on, or if the man is insulted by his boss, can the man insult his boss in his own office if he wants to keep the job? Yes or no? Yes or no? No, he can't. Okay, he cannot do that. So what he does is he comes back home and he takes that anger out on another person who is not as intimidating as his boss. So let's say, unfortunately, in most cases, it's his wife. So let's say the man comes back home from his work, and then he puts on all his anger into his wife, because the wife is less intimidating. The wife cannot obviously fire him from his job. So the man portrays this kind of actions into the wife. Let's say the man starts shouting at the wife for no reason. Okay, so this is known as displaced anger or displacement. And the next thing which happens is, if the wife then let's say that in most cases we have wives who are actually very nice, who tries to understand what their husband is going through. Okay, so they do not try to respond back. Okay, so they do not try to respond back. So the next thing is the wife, what they try to do is, so the wife, let's say the next thing is the wife tries to displace that anger onto their child. Okay, the wife tries to displace their anger onto the child. So this is known as displaced anger. So this type of behavior is known as displacement. So basically it's a redirection of emotion to a neutral person. Okay, so redirection of the emotion to anyone who is neutral or less intimidating. That is known as displacement. Have we understood displacement? Okay, good. So that is displacement. So we have talked about acting out, we have talked about denial, we've talked about displacement. Next one is dissociation. Okay, next one is dissociation. Dissociation is actually very traumatic. Okay, okay, so the next thing is dissociation. So what is dissociation? Dissociation, the word dissociation means to be separated or feeling separated from your own self. Let's say you feel like you are not yourself. Okay, so what happens is, let me explain it for you. So let's say we have a victim of sexual abuse. Okay, so let's say we have a victim of sexual abuse. And what happens is, if we have a victim of sexual abuse, and the next time the victim of sexual abuse goes and sees his or her abuser, okay, his or her abuser, what happens is the victim feels like the victim is all of a sudden the victim starts feeling numb. Okay, or starts feeling like she can't talk or he can't talk, or they start feeling like they are not who they are because they can't do what they want to do. Let's say the police is asking the victim to point out who the abuser is. Let's say the police is asking the victim to point out who the abuser is, but the victim starts starts choking, or like just starts being numb, like the victim cannot basically point out. Okay, so this type of thing, which happens to you when you want to do something but you can't because you're so afraid of what happened in the past by this certain person, this type of behavior is known as dissociation. Have I made myself clear? Dissociation, basically, what is dissociation? Dissociation is the feeling of being numb in the presence of a person who has previously caused you harm. Okay, who has previously caused you harm. Okay, so have you understood this? Have we understood dissociation? Have we understood dissociation? Okay, good. So a quick recap. Okay, quick recap before we move on. First and foremost, okay, if you have a patient who comes to your office and starts shouting at you for no reason, what is the name of this defense? Fast acting out. Very good, very good. If you have a patient who comes to you and sees you as your father or as her mother, what is this type of feeling known as? Transfer. Very good. If you see your patient as your young sibling, what is the type of psychological feeling projecting your yes, it's subject matter is very good. The next one is if you have a patient who has been diagnosed with cancer, but the patient keeps on working and the patient is not accepting the diagnosis. Good. Next one is if you have if you have uh, if you have a husband who comes back home from a bad day at work being shouted on by their boss, and then the husband starts shouting at a neutral wife. Okay, this place very good. Okay, next one is if you have a person who has been a victim of sexual abuse, but now the person comes in front of the abuser and now the person feel cannot feel anything, the person feels numb. Okay, this is known as dissociation. Okay, very good. Okay, very good. Okay, next thing is if you want to invoke an involuntary response, okay, what is the mechanism which you will use? If you want to invoke an involuntary response, what is the mechanism you will use? Classical conditioning. If you want to invoke a voluntary response, what is the mechanism you will use? Voluntary response, it's operant conditioning. Okay. Next one which we will do is we will move on to the next ego defense, immature defense. Okay, that is fixation. What is fixation? The fixation is basically partially remaining at more childish level of development, or this is the opposite of regression. Okay, we will talk about regression, but before that, let's talk about fixation, meaning that, for example, let's say a surgeon throws a tantrum in the operating room because the last case ran very late. So basically, fixation is basically staying I mean, okay, so fixation is, let's say you had a okay, so let's say you have a young child. Okay, let's say you have a young child who starts shouting every time the food is late. Okay, so we have a young boy. Okay, we have a young fat boy. Okay, like how I used to be. Every time the food was late, I used to keep on shouting. Okay, why is my food late? Why is my food late? Okay, so that's an immature defense. But right now, me as a grown up or me as an adult, every time the food is late, if I keep on shouting, is that a mature defense or an immature defense? Okay, me as a fat boy, okay, every food was late, I used to shout. Right now, if I shout when my food is late, okay, that's an immature defense, right? But for example, let's say that behavior where I used to shout when my food was late, let's say that behavior is still fixated. Let's say I still do the same thing which I used to do. So that type of behavior is known as fixation. Have I made myself clear? Okay, just 1 minute. Yes. So have you understood fixation? Yes or no? Okay. So basically, if you keep on doing the same thing which you used to do when you were a child, if you keep on fixated on that same problem as an adult, then this type of behavior is known as fixation. Okay. This type of behavior is known as fixation. Okay. Next one. Next one is, so have we understood fixation so that we can move on? Have to fixation and move. We want fixation once again, please. Okay, fixation. What is fixation? Let's say me as a young boy, I used to be fat every time my food was late. As a young fat boy, I used to keep on shouting so that my food will come faster. Okay, but that was an immature defense because I was immature. I was a child. But if I still have that kind of behavior right now, let's say I go to dinner and my food is late. If I keep on shouting like how I used to shout when I was a child for the fact that my food was late, okay, this type of problem or this type of response which I am giving is known as an immature defense response, and this is known as fixation. Okay, so basically doing the same things which you used to do when you were a child. Have you understood now, Dr. Rafi? Okay, hope we have. Okay, next one. Next one is idealization. Okay, so what is idealization? Idealization is basically a patient will usually boast about his physician. Okay, and what they will do is they will boast about the physician and his accomplishments while ignoring any flaws. Okay, so basically you're idealizing someone. Okay, so let's say you have a patient who comes to you who is so happy after your treatment that according to that patient you are the best doctor of the world. Okay, you are the best doctor. Does not matter how many times you messed up with any other physician in the I mean you messed up with any other patient in the past. Okay, but the patient, when he tries to describe you to someone else, the patient tells another patient that, let's say for example, we have Dr. Let's say the patient is talking about like one of the doctors from over here. Let's say the patient is talking about Dr. Karbasi, okay, and then the patient goes like, okay, Dr. Karbasi is one of the best doctors I've met in my life. Okay, he has never had a bad experience. Okay, and then he tries to be the best he can with his physician, with his patients. Okay, he's the best. There's no one like him. So if someone tries to idealize you, okay, this is an immature response. This is an immature response. Okay, so that's that. So this type of response is known as idealization. Okay, but why is that immature? Okay, that immature is it's an immature response because the patient is actively ignoring any flaws the doctor may or may not have. Do you understand? The patient is ignoring the flaws which the doctor have. Let's say that me as a doctor, okay, let's say that me as a doctor, I can treat a certain infection very well. Okay, let's say that I can treat staphylococcal infection very well. But when I have to treat any other infection, let's say I have to treat a streptococcal infection, for example, I do not treat streptococcal infections very well at all. Okay, but my patient, if he or she loves me, then what they would do is they would keep on telling everyone that, okay, we have Dr. Heidi over here who loves to treat his patient, who treats staphylococcal infection like it's the best treatment of the world, but he will not mention the fact that I cannot treat streptococcal infection because he or she is, let's say, idealizing me. Okay, so this is known as idealization. Okay, have we understood? Okay, good. So that is idealization. Okay. Okay, next one is identification. Next one is identification. So what is identification? Identification is basically, okay, what is identification? Identification is, for example, a resident, let's say a medical resident, putting his stethoscope in his pocket like his favorite attending instead of wearing it around his neck like before. Okay, so when you are a student, okay, so when you are a student, did you wear your stethoscope around your neck or put it in your apron? Neck. Okay, so let's say when you're you put the stethoscope around your neck, and this made sure, I mean, this looked like you were a student. Now, if we have very old, matured doctors who are walking around in the wards, Do they also wear the stethoscope around their neck, like how you wear the stethoscope around your neck in most of the time? No, they do. They actually do not. Okay, they actually not wear it around your neck. So what you do is, if you want to identify yourself as an old, matured doctor, okay, what you do is, instead of wearing around the neck like your young doctors, what you do is you do not put it, or I mean, you do not wear it around your neck. You put it on in your apron, so that whenever you need it, you can take it out. So next time, if anyone tries to seize you, they can identify you as a mature doctor. This type of defense is known as this type of defense is known as identification. Okay, you're trying to identify yourself as someone. Okay, as someone you are not. Okay, do you? Okay, did that make sense? Did you guys understand identification? Okay, mimicry, more or less. Okay, yes, more or less, to some extent it could also be mimicry. Okay, but this is basically identification. You're trying to identify as someone you're not. Okay, okay, good. Okay, next one. Okay, next one is intellectualization. Next one is intellectualization. What is intellectualization? Let's say that you have a patient who is diagnosed with a cancer once again. Let's say that you have a patient who has once again been diagnosed with a cancer. Okay, and what happens is, after being diagnosed with the cancer, the patient comes the very next day talking about the pathology of the cancer, whereas the patient is not a doctor. The patient is not a doctor. The patient is not supposed to know the pathology of the cancer, although there is nothing wrong with that. But what happens is, the patient tries to learn so much more about the cancer, so that eventually what would happen is, the patient tries to explain the pathology of the cancer to everyone. And at the same time, this allows the patient to be at some peace away from the stressful situation that the patient has the cancer. Okay, so let's say that you have a patient with pancreatic cancer, and the patient comes the very next day telling you that pancreatic cancer is caused by this is how it happens. And then, and the patient feels good about it, because the patient knows what type of disease the patient has. But the patient is avoiding the fact that the patient is very upset about the fact that the patient has the cancer. So being upset is basically the more matured way to deal with the cancer. But the immature way to deal with this is letting everyone know that you know about the disease, although it's not important that you know about the disease at all as a patient. Okay, so this type of defense, or this type of action, is known as intellectualization. Have we understood intellectualization? Yes or no? Okay, good. Very good. Okay, very next one. Next one is isolation. Okay, isolation of effect. And this is something which a lot of us have. Okay. So do you guys remember the first time that you guys cut open a cadaver? Yes or no? Do you guys remember the first time you guys cut open a cadaver? Okay, very good. And then this opening up of cadavers and removing of organs, this kept on happening for a long time in your anatomy. Am I correct? Yes or no? Yes or no? Did that keep on happening for a long time? Yes. So eventually, what happened was, even though the first time when you saw it happen, okay, yeah, it was a bit difficult for you to do it for the first time, but then when you kept on doing it for a long time, okay, it was very normal for you, okay. But when you try to explain this to your friend who is not a doctor, and you tell your friends that, okay, you have no idea exactly what happened today. I cut open the dermis, and then I went, and then I took open, and I got the liver out, okay, and it was really messy, this and that. And like, I found this, I found that, I found um, let's say that you are trying to describe the whole thing very graphically. Okay, let's say you are trying to describe the whole thing very graphically. So to you, it's not, I mean, to you it's not a problem, but to the person who is listening to you, to him or her, what you sound like is someone who has no effect, or you have no feelings, I mean, towards the whole thing, like how he or she feels. Okay, so this is known as isolation of effect. This is known as isolation of effect, meaning that what happens is, let's say you try to describe something in a very graphical details. You try to describe something in a very graphical details to someone who is not well accustomed to the whole procedure. This is known as isolation of effect. Another thing is, let's say for another example, let's say you see a murder. Okay, let's say you see a murder, but for some reason you are not scared of that murder, and someone tries to ask you how that murder happened, and you try to tell the whole thing very graphically without feeling a little bit of without feeling anything. Okay, so you have a dead face, and you just keep on explaining the whole murder situation to someone. This type of action is known as isolation of effect, meaning that there is no effect which you are feeling when you try to describe a stressful situation. Okay, have we understood each other? Have we understood each other? Have we understood the term isolation of effect? Okay. Okay, that's so basically what's isolation of effect? You, as a third year medical student, when you went back home, I mean, as a first year medical student, when you went back home and you explained to your friends about what you did today in your anatomy section, you cut open the whole cadaver, you took the liver out, you took this organ out, that organ out, okay, and you're describing the whole thing very actively, okay, but to the listener, okay, he or she might feel that you have no feelings. Okay, so that is isolation of effect. Okay. Okay. Okay, so we are done with isolation of effect. The next one is passive aggression. Next one is passive aggression. So far, have you guys understood the ego defenses which we talked about? Good. Next one is passive aggression. What is passive aggression? Let's say that you have a boss. Okay, the boss tries to be the boss is very rude to the employer. Okay, so instead the employer shouting at the boss, what the employer does is the employer shows up to work late every day. Okay, the employer shows up to work late every day, and this is known as, for example, these type of behaviors are known as being passively aggressive, meaning that you're not actively aggressive. What is active aggression? Active aggression is when the employer would start shouting at the boss, fighting the boss. Okay. Okay, so these are the examples of active aggression. What is passive aggression? Passive aggression is basically doing something which you know which you know will upset the other individual, but you are not doing it actively. You are doing it passively. So let's say instead of actively shouting at the boss, the employer shows up to work late every day. This is known as passive aggression, classic mother-in-law behavior. Okay, okay. I'm not sure how to describe that, but okay. But if you understand, okay, that's what it is. Okay, acting out versus passive aggressive. More or less, acting out is basically yes. Acting out is being okay, shouting at the doctor and this and that for no reason. That is acting out. Passive aggression is something else. Passive aggression is, let's say your boss is shouting at you, and instead of shouting back at the boss, you show up to work late every day. Okay, this is known as passive aggression. Are we clear? Are we clear on passive aggression? Yes or no? Okay. Okay, good. Okay, let's move on to the next one. Okay, the next one is projection. Before we move on to projection, can I see whether you guys remember the terms or not? Okay, first of all, what is the name of this defense in which the patient starts shouting at the physician because of a discomfort the patient feeling? If you have a patient who does not care about his carcinoma, and the patient goes to work every day, tries to the doctor's appointment, okay. Next one is, if you have a husband who comes back home, can you hear my voice? Is it speaking? Okay. Okay. How about now? Is this the voice better now? Is the voice better now? Okay, good. Okay, the last question was, let's say that you have a patient who, I mean, let's say that you have a husband who comes back home, and the husband was mistreated by their boss, and now the husband meeting their wife. Okay, so this very next one is, if you have a parent who sees their sexual abuser and then they feel extremely numb, and they feel like they are not themselves. Okay, okay, do voice or not? Yes or no? Okay, one second. Okay, do I have a clear voice now? Do I have a clear voice now? Okay, good. Okay, good. Okay, next one. Next one is, let's say that you have a patient. Okay, let's say that you have okay, for example, the next one is you have a young man who is shouting at the table because because his food did not come. We have an old adult man who is shouting at the table because his food did not come. Okay, that is very good. Fixation. Okay, next one. Next one is you have a patient who thinks the world of you. Okay, and tries to describe you as the best person in the world, but tries to avoid the fact that you have certain issues. Okay, idealization. Very good. Next one is you have a young doctor who is acting like an old doctor by keeping away the stethoscope away from his neck. Identification. Very good. Okay. Next one is you have a patient who comes to you and tries to describe the procedure of cancer without accepting what actually is the cancer. Okay. Intellectualization. Very good. Next one is you have a medical student who goes back home from his section of cadaver cutting and he describes this whole procedure. Okay, very good. Isolation. Okay, isolation of effect. Okay, so okay, very good. Okay, so looks like you guys have understood most of the thing. The next thing. Okay, so let's move on. The next one. Next one I want to talk about is the next one that I want to talk about is projection. Okay, the next one I want to talk about is projection. So what is projection? Projection is basically, for example, you have a man who wants to cheat on his wife, but accuses his wife of being unfaithful. Okay, so this is very easy to understand. Okay, so what is basically projection? This is basically you attribute an internal impulse to an external source. Okay, so what happens is, let's say that you have a husband and then you have a wife. Okay, so in that husband and wife, in that family, the husband feels the need to love other women except the wife. Okay, but what happens is the husband, instead of dealing with his own problem or instead of dealing with his own demons, the husband tries to accuse the wife of telling the wife that you have feelings for other men, whereas the wife does not have feelings for other men. It's him. He has the problem. He is the one who feels like he has feelings for other women, so he starts accusing his wife that the wife has feelings for other men, whereas the wife does not have any feelings towards anyone else except the husband. So this type of behavior is known as projection. This type of behavior is known as projection. So basically, what is projection? Projection is you're projecting your internal impulse to an external source. Okay, basically you're projecting your internal impulse to an external source. Okay, so that's what projection is. Have we understood projection? Have we understood projection? Okay. The next one is very easy to understand. The next one is most probably, yes, it's rationalization. Okay. So the next one is rationalization. So what is rationalization? Basically, rationalization is, let's say that after your USMLE step one, okay, okay, this is okay, this is a pretty good example. Okay, so let's say that after your USMLE step one, okay, you get a score which you are not happy with. God forbid that does not happen. Okay, I'm pretty sure every one of you will get good scores, but just saying, let's say, for example, God forbid, after your USMLE step one, you guys do not get the good scores. Let's say you guys get 196 or 197, or let's say you guys get 192. Okay, which you guys won't. Okay, please believe in yourself. It's just an example. Okay, so after you get that kind of score, okay, you try to explain your score to someone by saying that, yes, I got 192 on USMLE step one, but to be honest, that exam was not important to me anyways. Okay, Let's say if you talk about, if you talk like this, let's say you know how important USMLE step one is for you, but when you get a bad score, instead of accepting your score, what you do is you explain the whole thing, going like, yes, I mean, this exam did not matter to me as much anyway, so it's not a problem that I got a bad score. So you're trying to rationalize the whole situation. You're trying to rationalize the whole situation. So this is basically, this type of behavior is known as rationalization. This type of behavior is known as rationalization. Okay, have we understood rationalization? Okay, good, easy to understand. Okay, rationalization. Okay, okay, next one. Or your girlfriend breaks up with you and says she's not even that fine. Okay, yes, I mean, okay, so what? Okay, so if your girlfriend breaks up with you and then tells you that yes, she was not in love with you to begin with. Okay, so that's a type of rationalization too, I guess. I don't know. Okay, but the USMLE step one is the USMLE step one example is a better example. Okay, so let's say you get a bad score and then you try to rationalize the whole situation. Okay, instead of accepting the score. That's what it is. Okay, next one. Next one is reaction formation. What is reaction formation? Reaction formation is basically replacing a worded off idea or feeling with an emphasis on its opposite. What's the example? For example, a stepmother treats a child she resents with excessive nurturing and overprotection. Okay, so what is reaction formation? Okay, let's say that it's completely natural for a human being to like or dislike someone. Am I correct, or am I not correct? Is it completely natural for a human being to like and dislike someone? Yes. Okay. But what is unnatural is, if you dislike someone, does that give you the right to hurt that other person? Yes or no? No. It does not give you the right to hurt anyone, no matter if you dislike that person or you like that person. Okay. But what happens with people who have reaction formations are, let's say they have a person they do not like at all. Okay, so instead of staying away from that person, okay, or instead of saying something mean to that person, they try to overcompensate their feeling by showing everyone how much they love them. Actually they don't. Okay, they actually dislike themselves. Okay, so now this is, let's say this is a mother-in-law type of example which we were talking about. Okay, do you guys do we have any students over here who watches television, who watch TV dramas, okay? Yes, I'm sure we have a lot of students over here who watch drama shows. Okay, okay, even if you hate drama shows, you know what drama shows are. So that's I hate drama shows too. So that's basically what it is. Because what happens is, like, over there you will see a character who hates another character, but they in front of everyone they try to show how much they love how much he or she loves that other character. But actually in reality they hate that person. So that is known as reaction formation. Have we understood reaction formation? Yes. Okay, good. Very good. Okay, next one. Next one is regression. What is regression? Regression is basically, okay, let's say regression is, okay. So is it natural for an adult to start crying every time something bad happens in their life in front of everyone? No. Okay, it's very unnatural. Okay, if we have a patient, okay, if we have a patient who starts crying every time you give him or her a bad news, and he or she starts crying because he or she wants more attention from you through that crying. Okay, this is known as, this type of behavior is known as regression. Okay, first and foremost, have you guys realized why young children they like that young children they like attention? Didn't you guys ever realize that young children loves the fact when you provide them more attention? Okay, so if you have two child, okay, if you're loving one child more than the other child, you will realize that if it's a young child, the other child who is not being loved will start crying. Okay, why will the young child who is not being loved start crying? Because the young child would want to be loved too. So the young child starts crying to get more attention. Okay, if you have these kind of regrettory behaviors, okay, let's say as an adult you try to involuntarily turn back into your previous stressful type of behaviors, this is known as regression. This is very different from fixation. This is not fixation. Okay, fixation is basically your previous behavior which has been fixated in you, and this keeps on happening as an adult. Regression is basically you are regressing to your earlier immature behaviors. Okay, you are acting like yourself. I mean, you are acting like how you used to act when you were a child. Have we understood each other? Have we understood regression? Yes or no? Okay, good. Next one is repression. Okay, next one is repression. What is repression? Repression is basically involuntary withholding an idea or feeling from conscious awareness. Okay, so what happens is, what is repression? Repression is, for example, let's say you have a 20-year-old, okay, and let's say that this 20-year-old patient that you have does not remember going for therapy when his parents were getting divorced. Okay, so let's say this patient has a set of divorced parents, and the patient had to go through therapy when this stressful situation was happening in his or her life. And right now, the patient does not remember going to that type of therapies when the patient was young. Okay, so what happens is this type of behavior is known as repression. Repression is basically you're repressing the fact that you previously needed help, and it's an involuntary response. It's not a voluntary response. You actually do not remember what happened during that stressful time in your life, and that gets wiped out involuntarily from your memory. This is known as repression. Have we understood each other? Have we understood repression? Yes or no? Okay. Repeated. Okay. So once again, what is repression? Repression is basically you went, for example, there was a stressful point in your life, okay, when things were not right with your family, okay, so you had to go through psychological therapies, okay, but as an adult, what happened was after that stressful situation has passed away, you do not remember getting help for that stressful situation. This fact of not remembering that you needed help, this is known as repression. Okay, have we understood? Repression. You do not remember you needed help. That is repression. Repression. Okay. 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 Next one is basically easy to understand. This is known as a splitting. Okay. So what is splitting? Splitting is generally based on help. Yes, more or less. It's generally based on help. Okay. Repression. Okay, went through something stressful that you do not remember. Yes, that's what it is. Okay, next one is splitting. Okay, so this is something which I want to talk about. So what is splitting? Splitting is basically, let's say that you have a patient who describes you as all well, and then let's say you do something good to the patient. Okay, let's say you provide the patient with extra care and extra time. Okay, and now the patient loves you so much that the patient has all of the best things in the world to say about you. The patient keeps on telling you how good you are, describes you as one of the best physicians of the world. Okay, one of the best physicians with a kind heart, this and that. Okay, but let's say in his next appointment, you do not provide him with as much care as you did the last time, because of the fact that, let's say, this time you have a lot more patients to take care of, so you provide the adequate amount needed, but you do not provide that extra time which you provided the last time. So right now, what happens is, when this happened, right now the patient is describing you as someone who is the worst physician of the world. Okay. The patient is now telling everyone that this doctor is one of the worst physicians of the world. This doctor does not provide time to anyone. This doctor does not know how to treat anyone or any condition. And I will never come back to this doctor again. Okay. This type of behavior, splitting behavior by the patient, is known as splitting. This type of behavior by the patient, where the patient describes the doctor as all the very best, and then when the doctor does something which is not going well with the patient describes the doctor as not that well, okay, as one of the worst. This is known as splitting. Have we understood each other? Okay, so basically that is splitting. Okay, so having said that, so we're done with the immature defenses. Okay, we are done with the immature defenses. Okay, so can we do a quick revision before we move on to the mature defenses? Yes or no? Okay. 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 So what I will do is I will not ask everyone. Okay. I will need the help of two students. Okay, two physicians who want to perform an active participation, and the rest of you can hear. Okay, what I will need you guys to do is what I will need you guys to do is read the example and just read the term very quickly to see if you guys remember, and then I will test you guys whether you have understood the immature defenses or not. Okay. Okay. Can anyone answer via mic? Yes, that's what I will do. I will ask two students in active participation. Okay, read the example and then read the term, and then okay, and then I will move on to mature defenses, and I'll give you guys exactly 2 minutes. It's 11:09. I'll give you guys time till 11:11. Okay. Okay, it's 11:12. Is anyone ready to perform the active participations? Okay. How many students do we have? Okay, we have a lot of students. Okay, so what I would do is I'm going to ask the students by their name and they can answer the questions. Okay, I will ask everyone, no problem. Okay, so the first question goes to Dr. Maheshwari. Would you be kind enough to tell us what is the term you? Would you be kind enough to tell us what is the term used for the fact that, well, for example, you have an employer who is yelled on by their boss, and the employer comes home and yells at their wife? What is this behavior?
Displacement.
Very good. Next one is you have a patient who is a victim of sexual abuse. The patient sees the abuser and the patient gets numb.
Dissociation.
Very good, very good. Next one is you have a patient who has been diagnosed with cancer and the patient is asked to stay home, but the patient keeps on going to work.
Denial.
Very good. Okay. Next one is thank you so much, Dr. Maheshwari, for answering all
Thank
the
you.
perfectly. Next one is for Dr. Iman. Would you be kind enough to tell us what is the name of the defense in which the patient skips out on appointments because, or the patient shouts at the doctor for no reason?
Acting out.
Very good. Next one is if you have a patient who is, for example, let's say that right now you have a man who starts crying every time his food is late because he used to do the same when he was little. What is this type of behavior?
Fixation.
Okay, very good. Next one is you have a patient who is describing the physician as one of the best physicians of the world and then ignoring all his flaws. What is this problem?
Idealization.
Very good. Okay. Next one. Next one is okay. Let's see who else. Okay. So thank you, Dr. Iman, for participating. Can we go to the next doctor? That is Dr. Gianni. Would you be kind enough to tell us what is the term that we use for the fact that a young doctor puts the stethoscope away so that he does not look like a young doctor, he looks like a mature doctor?
Identification.
Very good. Next one is if we have a patient who is diagnosed with cancer, but the patient describes the cancer exactly by the pathophysiology instead of accepting the diagnosis. What is this type of behavior?
Intellectualization.
Very good. Okay. Can we move on to the next doctor over here? Thank you so much, Dr. Gianni, for performing. The next one is Dr. Kameshwari. Would you be kind enough to tell us what is the name of the behavior in which you try to describe a certain, let's say you dissect a cadaver and you try to describe this in a very graphic details to your friends who are not medicals? What is this type of behavior?
Isolation effect.
Mm-hmm. Very good. Next one is if you have a patient who is mad at you, but the patient will not tell you the patient is mad at you. Instead, the patient will come to your appointments very late. Okay,
Passive
every day.
aggression.
Passive aggression. Very good. Thank you so much. Okay, the next one is if you have a man who wants to cheat on his wife, okay, but instead, what the man does is the man accuses his wife of cheating on him. What is this type of behavior?
Projection.
Very good. Thank you so much, Dr. Kameshwar. That is projection. Can we have the next one to Dr. Mridula? Okay, the next one is if we have a man who tries to rationalize the fact that man did not do very well in his exam, and then he tries to tell everyone that that exam was not important for him anyways. What is that?
Rationalization.
Very good. Okay, next one is if we have a mother-in-law who really does not like the daughter-in-law, but in front of everyone, she tries to act like she loves her the most. What is this type?
Reaction formation.
Very good. Reaction formation. Okay, thank you so much. Can we have the next question to Dr. Adhanom? Dr. Adhanom, if we have a patient who is every time you tell her or him a diagnosis and the patient starts crying because this was how the patient used to act when the patient was little. What is the behavior? What is the name of this type of behavior?
Regression.
Very good, very good. Okay, we only have two more. So the next one is if we have a patient who went through a hard time in his life, but the patient does not remember that difficult time in his life, what is the name of this type of behavior?
Repression.
Mm-hmm. Very good. Thank you so much. And for Dr. Hassam, we only have one more left. And Dr. Hassam, would you be kind enough to tell us if what is the name of this behavior in which a patient describes a physician as all the best in the world when the physician is good to him, and when the physician does not provide him with the extra care he did before, now the patient hates the physician. What is this type of behavior?
Splitting.
Very good. Thank you so much. Okay, good. So we're done with the immature defenses. Now we will move on to the mature defenses. We will move on to the mature defenses. The mature defenses are sublimation altruism, suppression, and humor. Okay, sublimation, altruism, suppression, and humor. That's what the mature defenses are. Okay. So what are the mature defenses? First of all, what is sublimation? Sublimation is replacing an unacceptable wish with a course of action that is similar to the wish but socially acceptable. So what happens is, for example, a teenager is aggression towards his parents because of the high expectation is channeled into excelling in sports. So let's say, okay, so let's say that you are angry with someone. Okay, let's say that you are angry with someone. Okay, and you are so angry with that one person that you want to let's say beat up or hit that person. Okay, so that's how much you dislike them. Okay, that's how much you dislike them. But is it okay to hit that person? Yes or no? No, it's not okay to hit that person. Okay, so what you do is, instead of hitting that person, you go to the gym and then you hit or you punch the punching bag. Is that acceptable? Yes or no? Okay, that is acceptable. So you can go to the gym and you can take out the anger on the punching bag. Okay, but you cannot go and hit the person. So that type of behavior where you are trying to deal with your anger in a mature way is you try to channel that anger into something else. You channel that anger into sports. Okay, or for example, you're so angry with someone that instead of dealing with that person, what you do is you channel that energy into sports. For example, you try to excel into something else. This is known as sublimation. Okay, this is not a passive anger reaction. Okay, so this is known as sublimation. This is a matured response. Okay. Okay, next one. Have you guys understood sublimation? That is sublimation. You're subliming or you're channeling. Sublimation is basically the word channeling, meaning you're channeling your anger into something else. Okay, so anger channeling. Okay, that is sublimation. Next one is altruism. Okay, next one is altruism. What is altruism? Altruism is very easy to understand. Altruism is basically, let's say that you have a mafia boss. Does mafia bosses have a lot of money or not a lot of money? Fast answers, please. A lot of money or not a lot of money? Yes, they have a lot of money. They have a lot of money. So what they do is, altruism is, they know that this money which they have is, they do not, for example, let's say they have this money which was not given to them in the legal way. Okay, so what they try to do is, instead of, if they want to feel a little bit better about themselves, what they do is they try to make a large donation to a charity. Okay, they try to make a large donation to a charity. Okay, so this is known as altruism. Okay, so after they make the donation, they feel a little bit better about themselves. So because if they did not make that donation, they will keep on feeling very negative. If they felt negative for a long period of time, they could harm other people. Okay, they could either be angry at someone else instead of being angry at themselves. So they want to get rid of that anger. So what they do is they try to make a large donation to a charity. This is known as altruism. Have we understood each other? Have we understood altruism? Okay. Okay. Okay, good. Next one is, okay. Next one is suppression. Okay, next one is suppression. Okay, suppression. What is suppression? Let's say that after you are done with your USMLE Step 1 exam, after you get out from a USMLE Step 1 exam, is there anything you can do after you're done with your exam to change your score? Yes or no? No, there's absolutely nothing you can do after your exam is done to change your score. So what you do is, instead of focusing on what you could have answered right or what you could have answered wrong, what you do is you suppress that and you tell yourself that I'm going to think about the score when I realize the scores will be out. And before that, I will not think about the score. Before that, I will not think about the mistakes I made, or I will not do that. I will not do that. So this type of defense, this type of behavior is known as suppression. So once again, what is suppression? Suppression is basically, after, let's say, you are done with an exam, you don't want to worry about that exam because you know nothing can be done. So what you do is, instead you try to suppress that feeling and you deal with it once your score is out. Okay, so that is known as suppression. Okay. So basically, let's say that after you get out from your USMLE Step 1 exam, if you try to discuss your mistakes with someone, is that suppression, yes or no? No, that is not suppression. But let's say after you get out from your exam and you go back home and you enjoy your vacation okay? Is that an example of suppression, yes or no? Yes, that is an example of suppression. So you're basically not thinking about the exam. You will deal with the exam after you're done with after you receive the score. That is suppression. Okay. Next one. Next one is humor. Okay. So what is humor? Well, what is humor? Humor is basically you have a student. Okay, you have a student who is very nervous about the exam, but instead of being nervous, what he does is he jokes about the exam. Okay, so he goes like, okay, USMLE Step 1 exam, it's not a big deal. I mean, we know we have a lot of students who have given the exam, and I'm pretty sure that we can all do the same. So this type of behavior where he tries to normalize the whole situation of his nervousness and his stressful condition, this is known as humor, meaning that he tries to make things very light by turning his uncomfortable feelings to a more comfortable type of behavior. So this is humor. Okay. So have we understood humor? Have we understood humor? Okay. So if we have understood humor, so next one is, can I have one physician over here who can name the mature defenses, which I just talked about? And then we can move on. Okay. Can we have a physician who has not performed before and who would like to perform and just tell us the names of the mature defenses? Anyone who has not performed previously? Okay, Dr. Hussein has not performed. Dr. Nikki has not performed. Okay. Okay, so the first question goes to Dr. Hussein. Dr. Hussein, would you be kind enough to tell us what is the name of the behavior in which you have a teenager who is angry, but the teenager goes to the gym and works out?
Supplementation.
6 and
Okay,
7.
okay, young child said,
Yeah, sorry.
6
no problem.
and
Okay,
7 waffle.
yes, sublimation, you are correct. Okay,
Waffle,
okay.
waffle.
Next one is, can we go to, 1 second. Okay, next one is, can we go to Dr. Nikki? Dr. Nikki, would you be kind enough to tell us what is the name of the type of behavior in which the mafia boss tries to make a large donation because he feels bad for all the money he has earned?
Altruism.
Altruism, very good. Altruism, very good. Okay, next one again goes to Dr. Hussein. Dr. Hussein, would you be kind enough to tell us what
Yeah.
is the type of behavior in which USMLE Step 1 student does not think about the score until the time for the score is out? And
Suppression.
very good. The answer is suppression. Thank you. And the next one goes to Dr. Nikki once again. Would you be able to tell us what is the name of the behavior in which the medical student jokes about the exam because he's nervous about the exam?
Humor.
Humor, easy to understand. Thank you so much. So that's basically what it is. So we are done with all the defense mechanisms, okay? And we're done with the psychology portion of psychiatry. Do we have any questions from over here? Do we have any questions from over here? Psychology. Okay, now we will move on to psychiatry, to the pathology portion of psychiatry. Okay, so next time you guys get questions regarding the matured and immatured defenses, would you guys be able to answer with confidence, yes or no? Okay. Okay, good. Okay, good, good, very good. Next one, what I want to talk about is more or less. Yes, you guys will be more or less be presented with the similar first aid presentations. Yes, you guys will be presented with similar first aid presentations. Or if you understand what the thing is, there's no way they can there's no way they can stop you from answering the right answer if you understand all the terms properly. Okay, if you understand all the terms properly. Okay, now let's move on to the next one, that is psychiatry pathology. Do we want to take a small break before we move on to psychiatry pathology portion? Okay. Okay, so we can take a small break. How long do you guys want to take the break for? 10 minutes. Okay. So let's take the break for 10 minutes, and then after that we can come back. It's 11:27 as of right now. Okay. Okay, let's see each other in 10 minutes. Thank you. Okay, so do we have students back from their break? Is everyone back from their break? It's 11:37. Is everyone back from their break? Okay, good. Okay, so have you guys understood the matured and immature differences from the psychology portion of psychiatry? Okay, good. So was the explanations helpful? Did you guys understand on how to associate the texts? Okay. Do you guys realize how the questions will come and how the answers are supposed to be differentiated in between the terms in New World? Have you guys understood how the questions will come in New World and how to differentiate the answers? Yes or no?
Excuse me, doctor.
Okay, who am I speaking to over here?
Samra.
Okay.
Can you repeat it? Transfer and co-transfer, please.
Perfect. Of course I will.
Okay.
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 No
Thank you.
You're welcome. Okay, so we have a question from Dr. Hussain who wants to talk about transference and countertransference. Basically, what is transference? Transference is PT, meaning patient transfer. Patient will project their feelings about their doctors. Okay, let's say you have a patient who has never had a father, and now the patient sees the doctor as their father. This type of feeling is known as transference. Next one is if the doctor starts to see the patient as their young sibling. Okay, and then the doctor has a treatment bias. These type of behaviors is known as countertransference. Okay, so have we understood? Patient projecting feelings, transference. Doctor projecting feelings, countertransference. Okay. Okay, so let's move on. Okay, it's 11:40. We don't have a lot of time. So what we will be doing is we will be starting with the pathology section of psychiatry. The first thing that we want to discuss is infant deprivation effects. Okay, so what are the effects of depriving your infants? Okay, so what is infant deprivation effects? This is long-term deprivation of affection. Okay, so what happens is if you don't love your child for a long time, okay, let's say for more than 6 months, this can lead to irreversible changes. Okay, and it's in most cases, in severe cases, if you do not love your child at all, okay, for more than 6 months, and the child does not feel affected, because young child are very prone to emotional feelings, okay, because young child needs a lot of love and a lot of nurture to they need to be nurtured properly in order to be a healthy baby. So one of the components of being a healthy child is the receiving of love. If they do not get love for more than 6 months, that can lead to irreversible changes. And in severe deprivation, that can also result in infant death. Okay, that's that. Okay, so what are the long-term deprivation of affection? The long-term deprivation are failure to thrive, poor language, lack of trust, okay, then reactive attachment disorder, okay, and disinhibited social engagement, meaning that the child indiscriminately attaches to strangers. So these are the effects. So if you don't love your child for a long period of time, what are the things that can happen? That the child can fail, the child can fail to thrive, okay, the child can have poor social skills, okay, the child can have lack of trust, okay, then what else? The child can have disinhibited social engagement, okay, the child will go to someone who tries to provide love to the child, and that is also a very scary effect. So that is known as infant deprivation effects. Have you understood infant deprivation effects? Okay, good. Next one is child abuse. Okay, so what is child abuse? Child abuse is basically how many types of child abuse are there. Okay, child abuse basically how many types of abuse do we have? We have physical abuse, sexual abuse, and then we have emotional abuse. So what are the child abuses? First of all, it's very easy to understand that physical abuse, what are the signs? Let's say if you have a child who has fractures, bruises, burns, injuries in different stages of healing, including head traumas characterized by hematomas or hemorrhage. So basically, if you have a young child who comes to your clinic, and then you see that the child has different types of bruises, okay, so the child is going through physical abuse. Okay, that's physical abuse. Sexual abuse, the next one is sexual abuse. Sexual abuse is if you see a young child with any type of lesion or trauma during their around their genital, anal, or oral regions. Okay, so if you have any type of child who has these type of traumas or lesions around their genital areas, then this is a very concerning term. I mean, this is very concerning for the physician because these are all signs of sexual abuse. Okay, so that's that. So physical abuse are fractures and then bruises around the whole bodies, right? That's physical abuse. Sexual abuse is trauma around the genital lesions. Okay, trauma or lesions around the genital lesions. I mean the genital areas. And the next one is emotional abuse. What is emotional abuse? Emotional abuse is if you try to be aggressive to your child for no reason. Okay, all the time. If you are aggressive to your child for no reason and you deprive that of child of affect, okay, that is known as emotional abuse. Okay, so basically, how will you receive questions from this? One of the most important questions that you will receive from all of this is, what happens when you receive a child? What happens when you get a patient in your clinic who is a young child, and you have, and you make an assumption that the child is, you make a diagnosis that the child is being abused. Well, what is the next step of action by the physician? This is a very important UWorld question. So let me ask you, what is your next step of action if you have a child in your clinic who is a victim of abuse, either physical, emotional, or sexual? What is your, yes, report. Report to whom? Report to CPS, okay? CPS, meaning Child Protective Services. Very good, okay? So you have to call the Child Protection Service, okay? And they will come and then they will deal with the issue, okay? They will see whether the parents are at fault or not. And if the parents are found guilty of the abuse, then the child will be handed over to foster care. Okay, so basically that's what CPS, Child Protection Services. Okay, so that's basically that. So if you read through the whole thing, this is very easy to understand. This is not that very high yield, so we can skip out on most of this. The epidemiology is not high yield at all. Okay, you do not receive a lot of questions from over here, but if you have to read it, we will read it, which is the 40% of that are related to child abuse that is less than 1 year old. Okay, peak incidence of sexual abuse is 9 to 12. Okay, next one is 80% of young adults of emotional abuse will meet the criteria for psychiatric illness by age 21. So if you have a young child with emotional abuse, they can be psychiatrically diagnosed with a psychiatric disease by the time they are 21. Okay, that is emotional abuse. Next one is child neglect. Next one is child neglect. What is child neglect? Child neglect is basically failure to provide a child with adequate food, shelter, supervision, education, and affection. So these are all the rights of a child. Okay, so it's the right of a child to receive proper food, to receive proper shelter, to be supervised by an adult, to receive proper education, and to be loved, affection. Okay, so if anyone fails to provide these type of basic rights to a child, then this is known as child neglect. Okay, and basically, how will a child who has undergone neglect look like? Okay, the child will look like the child has poor hygiene. Okay, the child will be malnourished. The child will have malnutrition. Okay, so and then the child will be withdrawn. Okay, withdrawal meaning that if you try to go to the child and ask the child questions, the child will be so scared of adults, the child will not be able to answer anything to anyone. So this is known as child withdrawals. Okay, and then impaired social and emotional development, that the child will not be socially, if you have a child who was neglected as, if you have a person who was neglected as a child, that person will not have the same reactions as all the other adults. Okay, so they will have impaired emotional developments, and there could also be failure to thrive, meaning that the child can also fail to thrive, meaning that the child could also pass away or die. Okay, so what is your step of action if you receive a child who has poor hygiene, malnutrition, and you diagnose this as a case of child neglect? What is your next step of action? Fast answers, please. You as a physician. CPS. Once again, your step of action is local child protective services. That is your action. You have to call the child protective services. Okay. Next one. Next one is vulnerable child syndrome. Next one is vulnerable child syndrome. What is vulnerable child syndrome? Okay. Do you remember? Do you have you guys ever seen parents in your hospital who is extremely concerned about their child with very little, let's say with a very minor trauma? Okay. Let's say that the child has a very minor cut to their hands and the parents come crying their eyes off because to them their child is extremely vulnerable. Okay, this is known as vulnerable child syndrome. Okay, this type of syndrome is known as vulnerable child syndrome. It is not that high yield. Okay, you will not receive a lot of questions from this. That's why I'm not putting the stars over here, because the stars are not that high yield. Okay, you will not receive a lot of questions from this. And the reason why the parents usually act like this with their child with vulnerable child syndrome is because there might have been a possibility that in the past that the child had a very major trauma, after which the parents have gotten very vulnerable to the child. Okay, so this is known as vulnerable child syndrome or only child. Sure. Okay, but that's what it is. Okay, so have you understood child neglect, emotional abuse, vulnerable child syndrome, these things? Okay. Okay. Okay, good. Now, these are important. Okay, now these are very important. Okay, these are extremely important, and you will receive a lot of questions from childhood and early onset psychiatric disorders. Okay, childhood and early onset psychiatric disorders. The first disorder that I want to talk about, okay, the first disorder that I want to talk about is ADHD. Okay, so first of all, what is ADHD? ADHD is basically deficit hyperactivity disorder. Okay, attention deficit hyperactivity disorder. And okay, so first thing I want to talk about is ADHD. ADHD is attention deficit hyperactivity disorder. Okay, first of all, the onset. Okay, the onset of ADHD. Okay, the onset of ADHD. First of all, the onset is important because for diagnosing a patient with ADHD, you have to know the onset. Okay, the onset has to be before 12 years. Okay, so if you have a child, okay, who is acting like he has ADHD, but the age of the child is more than 12. Let's say the age of the child is 13 and the child does not have a previous history of having ADHD, then you cannot diagnose the patient as an ADHD patient. You have to diagnose the patient as something else, because for ADHD patient, the onset has to be before the age of 12. Okay, and the criteria. Okay, what is the criteria of ADHD? Okay, criteria is there has to be more than 6 months of limited attention and poor impulse control. Okay, these are the two things you have to remember. Okay, these are the two things that you have to remember, and these are if you can remember this, then you can easily diagnose ADHD. And once you diagnose ADHD, then you already know the treatments for ADHD. Can I does anyone remember the treatments I talked about for ADHD on my URL notes? What's the treatment for ADHD? What are the treatments? Fast answers, please. Amphetamines, then atomoxetine and stimulants. Basically, yes. So okay, amphetamines and methylphenidates. Okay, you guys remember methylphenidates? I also talked about methylphenidates. So these are the two things you have to remember about ADHD. First of all, what is ADHD? This is basically your child being hyperactive, impulsive. Okay, the child cannot have their attention focused on one thing. And who will complain about this? There are two people who will complain about this. Two people who will complain about this. First is the teacher. Next is the mother. Okay. Okay, because the mothers, they usually spend a lot more attention to their child. Okay, so mothers and teachers. So first one is by the teacher. The teacher will come and tell the mother that your child does not perform the task when the task is given to him, and he does a lot of things all at once. Okay, and then he does not have proper attention. Okay, he cannot focus on one thing at a time. And these are all sign symptoms for ADHD. And if this keeps on happening for more than 6 months, and the age of the child is, let's say, 7 or 8, then this is very concerning for the diagnosis of ADHD. Okay, so the criteria has to be lack of impulse control and limited attention span time. limited attention span time, and the onset has to be less than 12 years of age. Okay, how about the intelligence? Are ADHD students normally intelligent or more intelligent? ADHD, how about intelligence? Normal intelligence, very good. So they do not have any form of retardations. Okay, so they are normally intelligence. Okay, so we had another question from this one physician. Why do we use stimulants when stimulants can cause more increase in activity? Okay, so this is a very good question. The question is, I mean, the answer is the stimulants, what they do is, although the stimulants do increase the activity, but stimulants, what they do is they increase the activity in one particular thing. So let's say that the stimulants will make you do, so the stimulants will also increase activity, okay, but they will increase the activity with one task, okay, not multiple tasks. Okay, so what this will do is this will allow the student to focus more. So as a result, increase of focus. So focus increases because ADHD students lack focus. I mean, ADHD patients, they lack focus. So stimulants will help them increase the focus. Okay, so they can do one task for a long period of time, but this will prevent them from doing multiple tasks at once. Okay, have we understood ADHD? Have we understood ADHD? Okay, so what is the criteria? Fast answers, please, before I move on. Criteria for diagnosing ADHD. Criteria for diagnosing ADHD. For how long? 6 months. Yes, 6 months or more than or equal to 6 months. 6 months or more long of limited attention and poor impulse control. Limited attention and poor impulse control for 6 months or more is ADHD, and the onset has to be less than 12 years. So that is ADHD. Okay, next one which I want to talk about is, I'm pretty sure we all know what that is. That is autism spectrum disorder, or a child being diagnosed as being on the spectrum. Okay, so this is comparatively very common, comparatively a very common condition. The onset is basically in it's an early childhood onset. Okay, and what happens is, what happens is, it's an early childhood onset. Okay, onset is in childhood. And what happens is, over here you have a child. Okay, we have, this is known as ASD. ASD is autism spectrum disorder. Okay, how do you diagnose a patient with autism spectrum disorder? First of all, the first problem that the child will have is repeated or ritualized behavior. Okay, ritualized behavior. That's the first problem. Meaning, what they will do is, let's say that the child has let's say the child likes to throw the ball at the wall for some reason. Okay, for some reason you have a child who loves to throw the ball at the wall. But eventually, with normal children, what they will do is they will throw the ball on the wall for one day, for second day, and then by the third day they will get bored, and then they will move on to the next task. But what these childs will do is they will keep on throwing the ball to the wall for years. Okay, for years they will try to perform the same action over and over again. Either that, they will try to listen to the same music, okay, over and over and over again. Okay, so that's that. Okay, so this type of behavior is very concerning for autism spectrum disorder, to be diagnosed with autism. Okay, and they can also have social communication defect. Okay, meaning that they cannot communicate with other people in the society as fluently as all the other children. Okay, so these type of problems can be extremely concerning for a child who can be diagnosed with autism spectrum disorder. Okay, now what I want to do is I want to talk to you about some, let's say, intellectual disability. Okay, what are your ideas on intellectual disability? Okay, so intellectual disability, can they have intellectual disability, yes or no? Yes. Having said that, can they have more intellectual ability, not disability? Can they have more intellectual ability than the other people? Yes or no? Yes, very good. Okay. Albert Einstein. Do you guys know Albert Einstein was diagnosed to be on the spectrum? Okay. Okay. Einstein was diagnosed to be on the spectrum, meaning that he had more than average abilities and specific type of skills. Okay. So Albert Einstein. So it could either be a disability or it could either be increased ability. Okay. And how about their head size or brain size? Size of brain. Yes. Okay. They are known to have increased size of their brains. But for you world, okay, for you world, you can diagnose ASD by this first criteria, this first one, that is repeated behavior. They will focus on questions where they will tell you that you have a patient who has come to you who does the same thing over and over again. And when they mention these type of questions, the first diagnosis that should come to your mind is autism spectrum disorder. Okay, have we understood autism spectrum disorder? Okay. Okay, good. Okay, the next one that we want to talk about is conduct disorder. Okay, the next one we want to talk about is conduct disorder. Okay, so keep in mind how we are not reading the first aid right now. Okay, um, because once again, understanding the terms are more important in psychiatry than reading the first aid. If you can understand the terms, then the reading is easy. Okay, because the thing is, the questions will come about your knowledge regarding the terms, especially for psychiatry. They will not come from the texts, especially for psychiatry from first aid. So the terms are important. Okay, so we have to understand the terms, what terms mean what. Okay, the next thing that we want to talk about is conduct disorder. Okay, so what is conduct disorder? Okay, this is very common. You will see a lot of this behaviors if you are a primary school teacher. Okay, so what would happen is, okay, so these children, okay, with these children, what they would do is they have the criteria number one is they have aggressive behavior. Okay, and they have aggressive behaviors which will violate social norms. Okay, aggressive behavior violating social norm, meaning that they will try to do something that is socially not acceptable. For example, what will they try to do? They will be aggressive towards other people, and they will be aggressive towards other animals. Okay, or destruction of property, or try stealing or theft. Okay, and this will all occur, okay, conduct disorder, before the age of 18. Okay, before the age of 18. If you have a young adult, I mean, if you have an adolescent who is less than the age of 18 years, meaning he or she is not an adult, and those people have aggressive behaviors towards other people, or property, or theft, or tries to break down other or tries to kill animals, or aggressive behaviors towards animals, this is known as conduct disorder, and this has to be more less than 18 years. Have you guys watched Charlie and the Chocolate Factory by Johnny Depp? Have you guys watched Charlie and the Chocolate Factory by Johnny Depp? Okay, it's a very famous movie. Over there, do you guys remember that young kid who used to play a lot of video games, and then he got the Chocolate Factory ticket, and then he went inside the factory and he wanted to destroy everything? Okay, right. Right, more or less. Okay, so that is a young child with a that is a child with a conduct disorder. Okay, so if you have a young child who tries to act like this in front of everyone, that the child is aggressive, the child tries to destruct properties. Okay, and that is an example, that is extremely concerning for conduct disorder. Okay, if the conduct disorder continues for more than 18 years, okay, if it continues for more than 18 years, then this is known as, what is this known as? This is known as antisocial personality disorder. This is known as antisocial personality disorder. Okay, antisocial personality disorder. And this is very commonly asked, that if the conduct disorder continues for more than 18 years, that let's say the adult is still now aggressive towards other humans, violates the social norms, are into stealing, okay, harms animals, then this is known as antisocial personality disorder. Okay, so less than 18 conduct, more than 18 antisocial personality. Okay, so that's what it is. Okay, so have we understood conduct disorder? Okay, how to treat a patient with conduct disorder? The treatment of patient with conduct disorder. Okay, treatment is CBT. What is CBT? CBT is cognitive behavioral therapy. You have to counsel the patient, and you have to prescribe, you have to make the patient go therapy, psychotherapy. Yes, basically. Okay, so that's what it is. Okay, good. Now the next one is most probably, yes, it's a disruptive mood dysregulation disorder. The next one is disruptive mood dysregulation disorder. So what is DMD? Okay, disruptive mood dysregulation disorder. DMD. Okay, DMD. Okay, disruptive mood dysregulation disorder. First of all, the criteria. Okay, okay. First of all, what is disruptive mood dysregulation disorder? These are basically episodes of outbursts. Outburst. Okay. 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 So do you guys have you guys ever seen okay. So I know that a lot of you guys have traveled on air, okay? So traveled on flights. During long flights, have you ever noticed that there has been some times when there was this one child who was crying throughout the flight? Throughout the flight, the child cries throughout the flight, and it's very annoying for all of us. But you have to understand that it's extremely difficult for the parents, okay, because the parents know that the child crying is actually disturbing a lot of people, so the parents are trying to calm the child down. Okay, everyone is writing so annoying, so annoying. Okay, I know it's annoying. Okay, but we have to understand where the parents are coming from. Okay, it's extremely difficult for the mother, the father, because not only are they annoyed, they're tired, and they are embarrassed. Okay, so they are very embarrassed. Okay, so these type of outbursts from children, these type of outbursts where they have episodes of severe mood problems. Okay, severe mood problems, where they have episodes of outbursts. Let's say they start crying, they start screaming, and that does not stop. This is known as disruptive mood dysregulation disorder. Disruptive mood dysregulation disorders. Okay, and the has to be onset has to be less than 10 years. Okay, onset has to be less than 10 years. Okay, so once again, disruptive mood dysregulation disorder. Okay, you can have these type of examples in on flights, and let's say even in a movie theater. Okay, and there's absolutely nothing you can do. So this is not a disruptive mood dysregulation disorder. That's what it is. How do you treat a patient with disruptive mood dysregulation disorder? Treatment is basically, number one is CBT. Once again, therapy or cognitive behavioral therapy. Next one is stimulants. Okay, and another one is antipsychotics. Okay, do not worry, the treatment protocol is not that important as of yet. You will not get a lot of questions on what you use to treat patient with DMD. The only thing is you have to have the knowledge of identifying and diagnosing a patient with DMD in your world. Okay, okay. Before we move on, let's do the small revision and recapitulation. Okay, if you have a young child who is okay, so so if you have a young child whose teacher is complaining about the fact that the child has no focus in class, okay, and the child has cannot do one thing at a one time, ADHD. Okay, what is the age of onset? What is the onset of ADHD? Fast answers, please. Before 12 years. Very good. And how long does the criteria have to stay for? How long does the criteria have to stay for? More than 6 months. Very good. Next one. If you have a young child, okay, the child is visibly normal, but the child the child has an obsession of doing the same thing over and over again, wear the same type of clothes over and over again. Okay, autism. Okay, very good. Next one is if you have a young child who is into destroying school property, killing young animals, and conduct disorder. Okay, and then this one is if you have a young child who has outbursts of severe crying or shouting, and that does not stop, DMD. Okay, please remember the ages of each disease. DMD is less than 10 years, conduct disorder is less than 18. Okay, so that's that. Okay, okay, next one that we want to move on to is easy to understand. Okay, if I'm not wrong, it's disability intellectual disability. Okay, okay, intellectual disability. So what is intellectual disability? This is basically a global defect, abstract thinking, judgment, language, and learning. Okay, so this is not on this is very different from the normal intellectual ability of another child. That these childs are they have abnormal reasoning memory, and adaptive functioning is impaired. This leads to major difficulties with education, employment, communication, socialization, and independence. Okay, so basically how the best way you can diagnose a child with intellectual disability is, let's say that the child is doing persistently bad in in all the subjects in school. Okay, so how will you receive questions about this in your world? You will receive questions where the teacher will complain that the child is persistently doing very bad in all the subjects in school. Okay, so that's that. Okay, so that's sort of intellectual disability. Okay, having said that, there's one movie which I remember. I'm not sure if do we have any fans over here? Do we have any Bollywood fans over here? Bollywood fans. Okay, is anyone over here who is not a Bollywood fan? Tar is a meme, but okay, so that's not a very good. That's not a very good example of intellectual disability. The child you're talking about for Tar is a meme, but was had a specific disability. Okay, right. Okay, so we have this one. Okay, so Dr. Karbas. Okay, so if you guys have seen the movie, if you guys have seen the movie, this one by this famous actor. Okay. 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 Right. Okay. So this guy over here, Hrithik Roshan, who played this one movie. Does anyone have? Has everyone watched that movie? I'm pretty sure we have some students who has never watched that movie. Okay. For all the students who have not watched that movie. Okay. So that's what it is. Okay. So that there. Okay. So basically, it's an adult who has intellectual disability. I mean, it's a child who has an intellectual disability, and he keeps on repeating the same grade over and over and over again. He is stuck at the sixth grade for a long time. Then it takes him years to go from sixth grade to the seventh grade and stuff. So that's intellectual disability. That's what it is. Okay. Okay. If you have not watched the movie, okay, you can watch the movie. It's a good movie. Like it's the best. It's a good time pass. Okay, that's what it is. Okay, next one. Next one is oppositional. Okay, so have you guys understood intellectual disability? What is the most question you will receive from intellectual disability is the teacher will complain that the child is doing exceptionally bad in all the subjects for a long period of time. Okay, so that is intellectual disability. Next one is ODD or oppositional defiant disorder. ODD or oppositional defiant disorder. So what is ODD? This is basically, okay, ODD. How do you diagnose a patient with ODD? Okay, very interesting. The interesting part is these children, okay, they have aggression. Okay, these children, they have aggression towards authorities. Okay, authorities. Okay, I'm pretty sure every one of us had a little bit of ODD in school, that you did not like being told what you were asked to do. Okay, let's say that certain schools have certain dress codes. Okay, so for example, let's say certain schools have certain dress codes. Let's say you're not allowed to wear jeans in your school. Okay, for guys and even for girls, there are certain schools which do not allow the wearing of jeans. And then what you do is you go to school every day wearing jeans. Okay, you go to school every day wearing jeans, and when they ask you why you are not why aren't you listening to the authority, then you start being aggressive with the authority, especially the authority. This is known as oppositional defiant disorder. Okay, so have you guys understood oppositional defiant disorder? These children, they have aggression towards authority. Okay, so that's oppositional defiant disorder. How do you treat a patient with oppositional defiant disorder? Once again, treatment is CBT. Very easy. Cognitive behavioral therapy. Okay. Have we understood oppositional defiant disorder? Yes or no? Okay, next one. Okay, next one. What is the next one? Next one is selective mutism. There we go. Selective mutism. So what is selective mutism? First of all, okay. So selective mutism. Okay, what is selective mutism? Selective mutism, what this basically is first of all, this is okay, the first criteria is the onset has to be before 5 years. Okay, the onset have to be before 5 years. Okay, that's the first thing. Second thing is they're anxious regarding speech for more than 1 month. Okay, these are the two things. So first of all, they do not have a physiological or a pathological problem from talking. Okay, for example, we have a lot of conditions in which patients, they cannot talk, but these patients, they are, first of all, they are less than 5 years of age, and the problem with selective mutism is they have a certain sort of anxiousness which refrains them from talking, and this stays for more than 1 month. Okay, this type of anxiety will stay for 1 month. Okay, and what this usually happens is how the way you will receive these questions is they will tell you that you have a young child who has not been speaking for a long period of time. Okay, but then all of a sudden, when the anxiousness has wiped away, the child can start speaking again. So if the child starts speaking again, if the child starts speaking at a very late age, then the diagnosis could be selective mutism. Okay, that the child selectively wanted to be quiet. Okay, the child did not want to speak, so the child was selectively mute. The child did not have any physiological problems. So this is known as selective mutism. So basically what's happening over here is you have a young child less than 5 years of age and who is anxious regarding speech for more than 1 month. Okay. ODD is you do not like authority. You do not like your teachers. You do not like your supervisors. You do not like your boss. Basically, you do not like the police. Okay. Your problem with authority, that is ODD, oppositional defiant disorder. That is ODD. Okay. So in case of young children, ODD is basically the problem where they do not like their teachers or authority figures. Okay. Have you understood selective mutism? More or less, yes. Have you guys understood selective mutism? Selective mutism. Okay, you guys have not understood selectivism. Selective mutism. Once again, what is the problem? The child decides to not talk. Okay, the child decides to not talk by themselves. And this usually happens in less than 5 years of age. And the reason why the child does not want to talk is because the child is anxious for talking, and the anxiety stays for at least more than 1 month. These are the two things. That is selective mutism. How will you receive questions about selective mutism in UWorld? The way you will receive questions about selective mutism is they will tell you that you have a that you have a child who started speaking all of a sudden at the age of 7 years. Before this, he was diagnosed as a mute patient. So if the child starts speaking all of a sudden out of nowhere at the age of 6 or 7 years, then previously the child had selective mutism, but the child can speak normally. The child has no problems, that the child has no physiological problems when speaking. So the child starts speaking when the child wants to speak. Before this, the child did not speak because the child was not, because the child was anxious about talking. Okay, so that's what it is. Yes, it's less than 5, meaning that this type of behaviors has to, this type of problems have to stay in the child before the age of 5 years. Okay, you cannot say the child is selectively mute if the child has spoken and then the child stops speaking again. Okay, that is not selective mutism. Selective mutism is the child never speaking and then speaking all of a sudden. Okay. Okay, next one is, okay, next one, what is the next one? The next one is separation anxiety disorder. Okay, so what is separation anxiety disorder? Okay, separation anxiety disorder. Okay, uh, this is basically your, okay, once again once again once again your separation anxiety disorder is your right, okay, separation anxiety disorder. Okay, so well, what is separation anxiety disorder? This is basically the fear of being separated from home or an attachment figure. Let's say in most cases it's the mother. Okay, so criteria, what is the criteria? Okay, criteria, what is the criteria? That is fear of separation, fear of separation from mother, from home or authority figure for more than how long? 4 weeks. Okay, so this type of feelings has to stay for more than 4 weeks. That is the fear of being separated from the home or fear of being separated from the mother, that lasts for more than 4 weeks. Okay, and the thing is, it can be normal up to age 4. Okay, but its diagnosis is done after 4 years of age. So let's say up to the age of 3 to 4, it's normal. But if if this type of behavior stays in the child after the age of 4, then this is very concerning for separation anxiety disorder. Separation anxiety disorder. Okay, so what these childs will usually do is, let's say that these child, they will go to school and then they will complain to their teachers that they have a stomach ache or then they have a tummy ache, and then the teacher will eventually believe them. But the problem is they'll keep on doing it every day so that they can go home or they can go to their mom. Okay, so this is known as separation anxiety disorder. Okay, so that's that. And if this stays for more than 4 years of age, then it's abnormal, and then you can diagnose it as separation anxiety disorder. And these type of feelings have to stay for at least more than 4 weeks. Okay, so that is separation anxiety disorder. Okay, have we understood separation anxiety disorder? Okay, okay, good. Okay, so the easiest way that you guys can learn is, first of all, you guys have learned all the things. Okay, what you guys have to underline when you read, if you once again, is that you just underline the ages. Okay, that is important. Okay, onset and underline the ages. That's all you need from over here. And the next thing, you just have to understand what the term is. It's pretty easy, but at the same time it's a bit difficult if you do not understand the whole thing. So try to understand psychiatry and you will get all the questions right. Do not read through first aid by not understanding anything. Okay, understand psychiatry is very important. Okay, next one is Specific learning disorder. Specific learning disorder. What is specific learning disorder? This is a problem in which a child has an issue with a specific subject. Okay, specific learning disorder. Okay, issue with learning a specific subject. Either it could be maths or reading or writing. That is specific learning disorder for more than 6 months. 6 months. Okay, and if these type of problems they stay for 6 or more months, this is known as specific learning disorder. Okay, okay, and the general functioning and intelligence of these child, are they normal or not normal? Are they normal or not normal? They are normal. Okay, they're very normal. Okay, so this is the child that this one physician was talking about from another Indian movie. Okay, so that's that. Okay, so that's another. Okay, so that's that. Meaning that if a child has a problem with only one type of skill, okay, let's say no matter what you do, the child is not good at maths. Okay, or no matter what you do, the child is not good in arts. The child is not good in either maths or arts or reading. So it's a specific type of learning problem or disorder which the child has, and this will usually stay for more than 6 months, 6 or more months. Okay, that's that. The last one, hopefully, yes, the last one is Tourette syndrome. Okay, the last one which we have to discuss is Tourette syndrome. What is Tourette syndrome? Tourette syndrome. Tourette syndrome is basically, okay, what is Tourette syndrome? One second. Okay. One second. Okay, all right. Okay. So Tourette syndrome. Tourette syndrome. What is Tourette syndrome? What is the number one criteria for diagnosing Tourette syndrome? Number one, the age of onset has to be more than 18 years. Okay. And there are two types of problems in which they are called tics. Okay, tics. Okay. Do you guys have any idea what tics are? Do you guys have any idea what tics are? Tics? TICS. Does anyone know what tics are? Or tics is? Yes. Okay. Tics. So we have two types of tics. One's a verbal tic. Another one is a motor tic. Okay. Verbal tic. Another name for verbal tic. Another name for verbal tic is coprolalia. Is coprolalia. Okay. Well, what is coprolalia? Okay. The spelling is COPROLALIA, coprolalia, meaning that you say obscene things, obscene speech in front of people and you do not have any control over it. Okay, let's say you start saying slangs out of nowhere in front of someone, and you guys, and those patients have no control over it. Have you guys seen any video or seen any patients with a verbal tic? Okay. Oh, so that's that. So that's a tick. Okay, that's a tick. Another one is a motor tick. Okay, another one is a motor tick. What's a motor tick? Motor tick is basically your same thing in which you do not have control over a certain movement and keep on doing that movement over and over again. Like for example, twitching movements of the face twitching. Okay, so those are a type of ticks, and you keep on doing it over and over and over again, and you do not have any control over it, and this is known as motor tic. Okay, and if we have these type of problems in a patient with, less than the age of 18 years, okay, and the tics will usually last for more than 1 year. Okay, so that's that. The tics will usually last for more than 1 year, and these problems will stay for less than 18. These problems will arise before the age of 18 years. This is known as Tourette syndrome. How do you treat a patient with Tourette syndrome? The treatment for Tourette syndrome is basically, okay, treatment. Unfortunately, you cannot give CBT for these patients. Okay, to some extent you can give some behavioral therapy, but it will not work. Okay, so what you can do is for high, for very distressing tics, what you can prescribe is antipsychotics. Okay, antipsychotics, and you have antipsychotics such as haloperidol. Okay, and those work really well for ticks. Another one is, okay, you can give alpha 2 agonists. Okay, why do we give alpha 2 agonists? Alpha 2 agonists, do they increase sympathetic activity or decrease sympathetic activity? Decrease sympathetic activity. Okay, so increased sympathetic activity is associated with increased bodily movement or loss of impulses, and the alpha 2 agonists, okay, what they will do is they will decrease the sympathetic activity, and alpha 2 agonists can be used for Tourette syndrome. Okay, so alpha 2 agonists can be used for Tourette syndrome. Okay, so we're done with that. Okay. Okay. Can I give you guys 2 minutes to read the whole thing before we move on? Okay. To read the whole thing, just go through them. Try to understand whether you understand the terms or not, because understanding the terms are all you need from psychiatry. That's how you can diagnose and easily answer. Because if you do not have any idea what's going on, then you will not have the right diagnosis. So try to read it for 2 minutes. Okay, and then I will ask you the questions, and then I can get some answers. Okay, in 2 minutes, whoever is done, if they are confident, they can tell me right now, and I'll ask them the question right now. Just say done after you have read through so that you can answer the questions, and I will ask you. Is anyone done? Okay. Anyone else? Anyone else? Okay. Okay, good. So we have had Dr. Mridula and Dr. Iman perform previously. Okay, so let's ask our questions this time to Dr. Tari, and Dr. Basi, and Dr. Hussam has performed previously. Okay, so let's ask these questions to these physicians right now. The first question goes to Dr. Tari. Would you be kind enough to tell us the diagnosis for a patient who has a problem repeating the same thing over and over and over again? Dr. Tharn, can you hear my voice? Can you hear my voice?
Yeah, I can.
Okay. Is the voice breaking again? Or is it better now?
It was breaking a little bit. I kind of missed. All I heard was over and over again. That's what
Over and over again. Okay. Can you hear the voice now? Is the voice better?
Yeah.
Okay, good. So the question was, so basically, I think you have understood what I meant by over and over again. The diagnosis is autism spectrum disorder, am I correct?
Yeah.
Okay, perfect. The next question is, if you have a young child who comes with his mother to your clinic, the child's mother is complaining that the teacher has a problem with the child, with the fact that the child cannot focus in one subject for a long period of time, and the child cannot complete a task in due time. What do you think the diagnosis is?
ADHD.
Okay, what is the onset for patients for ADHD?
12.
Before 12 or after 12?
Before 12, and it has to be greater equal to 6 months.
Perfect. So it has to be more than or equal to 6 months. Good. Next one is if you have a young child who has a problem with violating school property and harming animals before the age of 18, what is the diagnosis?
Conduct disorder.
And it's more than 18?
Antisocial personality disorder.
Antisocial personality disorder. Very good. Okay, so if you have another child who is on flight with you, and the child is having episodes of intense outbursts and shouting and screaming, and the age of the child is less than 10 years, what is your diagnosis?
DMD, disruptive mood dysregulation disorder.
Right, very good. Okay, and the last question is, if you have a patient who comes to you with, okay, so if you have a child who has a problem with passing grade in due time and keeps on repeating grade over and over again, what do you think the diagnosis is?
Disability.
Intellectual disability. Okay, perfect. Thank you so much. So that's basically the main problem. Okay, so thank you, Dr. Tariq, for performing. Okay, the next question goes to Dr. Karbasi. Okay, Dr. Karbasi who also wanted to perform. Okay, so Dr. Karbasi, would you be kind enough to tell us? Would you be kind enough to tell us if you have a child who has an anxiousness for speaking for more than 1 month, and the age of the child is and the child has not spoken for the last 5 years, and now all of a sudden the child starts speaking. What what was the diagnosis of the child before the age of 5 years?
Selective mutism.
Selective
Selective
mutism.
mutism.
Very good. Okay, next one is, if you have a young child who keeps on crying in school after the school ends because his mother is late to pick him up for a long time. Okay, and this stays for 4 weeks or more.
Separation anxiety disorder.
Separation anxiety disorder. Okay, so the child has anxiety for being separated from the mother. Okay, good. Next is, if you have a child who is exceptionally good at maths, but he is doing really, really, really bad in arts. What is the
Specific learning disorder.
specific disorder? Okay, next one is, if you have a patient who comes to you with the complaint that whenever he goes out on dates with other people, he cannot control what comes out of his mouth, and he keeps on blurting out slangs out of nowhere, and he cannot control them. And this has been happening for the last almost 1 year or more. The age of the patient, the first time this happened was when the patient's age was 16 years.
It's
What do you
Tourette
think
syndrome.
of Tourette syndrome, and
Yeah.
what type of tick is this?
That's the like what do you say?
That's the verbal tick. Okay.
Robotic. Yeah.
Yeah, verbal take. Another name is corporalia. All right. Thank you so much, Dr. Garbasi, for forming. That's
Thank you.
exactly. Okay, so that's that. So they're all the psychiatric pathological conditions. Have we understood everything before we move on? Because these are very high. You will get a lot of questions from this.
Like, sorry, one question too. The disruptive mood dysregulation disorder. Is it like just like if a child is like, for example, in a plane or in a car or somewhere for a long time and he's not really happy and then gets angry about the situation, or?
Okay, there's no particular stimulus, to be honest. The stimulus, no one really knows what stimulus is. This could be anything, to be honest. This all depends on the patient, the child. So that's that. Okay. So it's very hard to say what the stimulus is. We were not sure if the stimulus is the flight or the ride, or if anything upset the child. But whatever it did, the normal response is to cry for a little amount of time and then stop the crying. So, but these child, when they start that crying, they go on crying for so long. So that's that. Okay. That's that. Okay. So hope that answers your question. Next one
Yeah, thank you.
is Dr. Osam. You're welcome. Okay. Next one, Dr. Osam. Dr. Tourette syndrome, is that yes. That is correct. Okay, the new Joker. If you guys watched the new Joker movie, yeah, that is something which the Joker has. Good. He can control it. Okay, do I have a better voice waking? So, voice waking up. And Okay, so can you guys hear my voice now? Is the voice better? Is the voice better right now? Okay, good. Yeah. Okay, perfect. Okay, so that's what it is. Okay, so we are done with the Tourette syndrome. Okay, so let's move on to the next one. Conduct disorder. Conduct disorder is basically where the young child tries to disrupt school properties, harm animals, okay, break down things, okay, tries to harm other people before the age of 18 years. This is known as conduct disorder. Okay, next one. The next one is ADHD symptoms after 12 years. So basically, ADHD, the onset has to be before 12 years of age. Okay, ADHD onset has to be before the age of 12 years, and it has to stay for 6 months or more. No, before 12 years. It has, if it is after 12 years, it's not ADHD. If the child did not have ADHD before 12 years, and if the child starts lacking attention, then this is another problem. This is not an ADHD. Okay. Okay. Good. Okay. Good. Next one. Next one is, okay. 1 second. Next one is, if we did not miss anything. Okay. Okay. Orientation. Okay, what is orientation? Orientation is basically the patient's ability to know the date and time where they are. Okay, so basically if you do a mini mental state exam, can you guys hear my voice? Is the voice better? Once again. Okay, can you guys hear my voice now? Is the voice better now? Is the voice better now, or is the voice still breaking? Still breaking? Okay, is the voice better now? Okay. Okay, good. So what we were doing is we were talking about orientations. Okay, so what is orientation? Orientation is basically the ability of the patient. Orientation is basically the ability of the patient to stay oriented to the date and time. Okay, have you guys ever done a mini mental state exam or a mental state exam? Okay. Okay, before we move forward, ODD. ODD is basically when the child has problems with authority. The child has a problem with the teacher, supervisor, anyone in the authority in the school. That is known as ODD. Okay. Having said that, let's move on to orientation. Orientation is basically the have you understood ODD, Dr. Ahmed? Before I move on, ODD, very easy to understand, oppositional defined disorder, meaning that you are not happy with your authority. Okay, so that is ODD. Yes, even mother to some extent, if the mother is also an authority figure. So yes. Okay, good. Orientation. So a patient who has loss of orientation, meaning when do we say that the patient is disoriented? Disorientation meaning that the patient has no idea what the date, time, place, person, or whatever it is. The patient has no idea where they are, what time it is, who they're talking to. This is known as disorientation. One of the most common cause of disorientation, number one. What is the number one cause of disorientation? Let's see who knows. Alcohol. Have you guys ever seen or heard a drunk person talking? Have you guys ever seen a drunk person? Okay, drunk person. Okay, I'm pretty sure you guys have seen drunk person. If you have not seen them in real life, then you guys might have seen them in movies. Okay, so that's what it is. So drunk people. Okay, so if you have dealt with the drunk people, then you know that drunk people, they have no idea who they're talking to, where they are. Okay, if they're very drunk, then they have no idea where what time it is. Okay, so that is disorientation. Alcohol is the number one cause of disorientation. Then you can also have drugs. Then some other causes are, for example, hypokalemia or hyponatremia. Okay, head trauma. Okay, so these are some of the common causes. Hypoglycemia is a cause. Okay, even in certain infections, for example, meningitis, the patients get disoriented. Okay, sepsis. So these are some important cause of orientations. And if the person has to lose orientation, there's an order in which he loses orientation. The order is, first he will lose time, then he will lose track of place, then he will lose the track of the person. So first he will have loss of track of time, then place, then person. So TPP. Okay, so TPP. Okay, that's what it is. So this is known as disorientation or orientation. Are we clear? Okay. 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 So do you guys want to take a small break before we move on? Yes or no? Okay. We are covering some big pages over here because they have a lot of information. We cannot just simply jump through the pages by not understanding what they're talking about. Okay. So once again, it's about the quality, not the quantity. So that's that. Okay, so till now, have we understood all the high yield things that we talked about? Ego defenses, conditionings. Then we talked about childhood psychiatric disorders. Okay, are we confident about these things? Okay, good. How long do you guys want to take the break for? Okay. Okay, so what we can do is, okay, 10, we have tenors. Okay, no problem. We can take the break for 10 minutes. Okay. Then we can come back at 12:55. Okay. Okay, we will. Okay, is everyone back from their break? Okay, good. Okay, perfect. So we are back from from our break, and we are ready to discuss the next part of psychiatry. Okay, and we will rush through them pretty fast because they're pretty easy to understand. Okay. So with that being said, let's not waste any further time. Okay, next one. So the next one that we want to talk about is amnesia. Okay, so basically we want to talk about amnesia. I'm pretty sure you guys know what amnesia is. We have just studied neurology. And if we have to talk about one system that is associated with amnesia, what is the name of that system in the brain? Which system, which disruption of which neurological system results in amnesia? I'm talking about a system, not a specific structure, and the system is the limbic system. Very good. Okay, very good. So if we talk about amnesia, we have to talk about retrograde, anterograde, and Korsakoff syndrome. What is retrograde amnesia? It is the inability to remember things that occurred before a CNS insult. Okay, so let's say you have a patient who have had a head trauma, okay, and the patient has the inability to remember things that occurred before the head trauma. Okay, so before the head trauma, what happens is, let's say the patient does not remember what happened before the head trauma. For example, let's say the patient was going somewhere. Okay, so let's say the patient was going to Times Square. Okay, so let's say in New York, we have this place called Times Square. And let's say the patient was on his way to the Times Square. When he got out from the subway, he got hit in the head by the moving train. Okay, very unlikely, but happens. So that happens. And then after the trauma, if you ask the patient, where were you going? The patient will say that I do not remember where I was going. And this is known as retrograde amnesia. This is known as retrograde amnesia. Next is anterograde amnesia. What is anterograde amnesia? This is the inability to remember things that occurred after a CNS insult, meaning that after a trauma, okay, let's say after the trauma, you ask the patient to remember something. Let's say the patient is a trauma patient in your hospital. Okay, let's say you have a trauma patient in your hospital and you give the patient three things to remember. Let's say you give him a color, red, an object, let's say table, and then place, let's say USA. So red, table, USA. And then and then you ask him to remember these three things, and after you do a whole exam, you ask the patient that, okay, what were the three things that I asked you to remember? And the patient cannot remember the three normal things that you should be able to recall. That is red, place, USA. And this failure to remember new memories or new information after trauma is known as anterograde amnesia. Okay, these are very easy to understand. That's nothing new. Okay, that is anterograde amnesia. So one is before, so retro meaning before, and antero meaning after. Okay, after a CNS trauma or CNS insult. Okay, next one. Next one is Korsakoff syndrome. Okay, so what is Korsakoff syndrome? Well, first of all, which vitamin deficiency is associated with Korsakoff syndrome? Fast as please B1, and we all know that. Okay, so thiamine deficiency. And the amnesia that occurs in Korsakoff syndrome is basically anterograde, which will occur more than the retrograde, meaning the patient will have formation of new memories, which will be a problem, but they will have, they can still remember their previous memories, but they cannot form new memories. This is known as, these type of amnesias are seen in Korsakoff syndrome. Along with this, there is also disruption and destruction of the limbic system, especially the mammillary bodies and anterior thalamus. Okay, please, can anyone tell me really quick what are the components of the limbic system and what is the mnemonic that we used to remember the components of the limbic system? Fast answers, please. Hamid, very good. Okay, for Hamid, that's hippocampus, amygdala, mammillary body, anterior thalamus, cingulate gyrus, and entorhinal cortex. Okay, entorhinal cortex. These are all the components of limbic system which we studied. Okay, I said the answer for you guys. Okay, no problem. I don't want you guys to stress yourself out. Next one is this is seen in alcoholics. We all know that in alcoholics we see this, and this is known as Warning's encephalopathy. Okay, and once again, if you have an alcoholic patient who comes to your emergency department before prescribing glucose, what are you supposed to prescribe before you prescribe glucose? B1, very good. Thiamine, okay, thiamine. But because if you prescribe glucose to an alcoholic patient, this can result in warnic encephalopathy and Korsakoff syndrome, and that's that. Okay, okay, next one. Next one is dissociative disorders. Next one is dissociative disorders. How many types of dissociative disorders do we have? We have three types. That is depersonalization, dissociative amnesia, and dissociative identity disorder. Okay. So what is depersonalization? That is the persistent feelings of being detached from one's own body, thoughts, perceptions, and actions. Okay. So what the problem is? These patients, they are completely dissociated from their body, meaning that they do not realize, meaning that basically, okay, so let me explain to you how the situation is. Okay, okay, 1 second, let me explain how the situation is. Okay, so how does a person with derealization disorder feel? Okay, let's say this is the bed. Okay, this is the bed. This is the person who has the problem. He is sleeping on the bed. Okay, if he's lying down on the bed, to this person who has the dissociative disorder, this person will feel like he is looking at himself from over here. Okay, so this person is actually feeling like this person is dissociated from his own body, and he is standing over here looking at himself, and all the things that are happening to this person is actually being visually seen by himself over here from a distance. This is known as dissociation feeling, or feeling of being dissociated from one's own body, thoughts, perceptions, actions. Okay, and even the environment that he is in. This environment, what is this type of environment? This is the type of, let's say, a very comfortable sleeping environment, sleeping position. Okay, and he will feel completely dissociated from it. This is a very, very scary feeling. This is a very scary feeling where you feel like you are away from your own body, and you are standing beside yourself, and you are looking at yourself lying down on the bed. You're completely dissociated from the body. You're completely dissociated from the feeling. This type of feeling is known as derealization or depersonalization disorder. Are we clear? Are we clear? Yes? Okay, good. Now, the thing is, if the person feels dissociated from action, okay, if the person feels dissociated from action, this is known as depersonalization. Depersonalization. Okay, if the person is dissociated from environment, this is known as derealization. Depersonalization, dissociated from action. Derealization is dissociation from the environment. Okay, so that's what it is. Okay, so are we clear on dissociations? Okay, next one. Very good. Next one I want to talk about is dissociative amnesia. What is dissociative amnesia? Dissociative amnesia is the inability to recall information, meaning personal information, after a severe trauma or stress. So this is a sort of anterograde amnesia. Okay, this is a sort of anterograde amnesia, but what happens is these people over here, what they have is they cannot remember who they are. Okay, anterograde amnesia is basically the inability to recall red, then the color red, then the name of an object, table, and the name of the country. Okay, this is more or less anterograde amnesia, meaning that the patient knows who the patient is, but the patient cannot form new memories. But dissociative amnesia is after the trauma, the patient forgets who the patient is. Patient forgets their name, address, okay, family, personal information, very personal information, name of the wife, children. The patient does not remember these things. This is known as dissociative amnesia. This is also associated with another condition. This is known as dissociative fugue. Okay, dissociative fugue. What is dissociative fugue? Dissociative fugue is when these patients with dissociative amnesia, they walk out of the house and they roam around the street without remembering where their address is. So they can go outside of the house and they can leave the house. Have you guys ever had any old family member with a history of dissociative fugue? Anyone? Anyone? Okay. Okay. This is not sleepwalking. This is not sleepwalking at all. Sleepwalking is completely different. Sleepwalking is completely different. This happens in the stage 3 and 3. Okay. So this is not sleepwalking. This is basically the patient is aware, but the patient does not remember where he lives. So he thinks his house is not his house. So he goes away from his house and wanders off in the street. And then he tries to find back his address. So he's just So he's just like wandering around. That's it. So that is known as dissociative fugue. Okay. Are we clear on dissociative fugue and dissociative amnesia? Okay. Next one. Next one is, have you guys watched that movie? What's the name of that movie? Split. Have you guys watched Split? Do we have any fans of this movie Split? Okay. Split. Okay, Split is basically about a person who has multiple personalities. Okay, this is a person who has multiple personalities. Okay, multiple personalities, and those personalities, they come in life and they take their own, they form their own reality when these personalities are taking place. For example, let's say that this guy over here, okay, this guy over here, this guy, his name is John. Okay, so let's say his name is John. Okay, so John has dissociative identity disorders, meaning that John has two other personalities living with him. So this person, John is a very good guy. John likes helping other people. Okay, John, he likes to give charity. But there's another personality in this character who is named, let's say, Eddie. Okay, and when this personality comes out in this character, this guy, Eddie over here, is basically your bad guy, you know, like he loves hurting people. He does not like giving charity at all. Okay, he hurts women, he hurts children, he hurts old people. These are basically the same person, but two different personalities. Then you have another personality. Let's say this personality is the personality of a woman. Okay, and this personality is Jane. Okay, so this personality of this guy over here, now he is Jane. Okay, so Jane is basically a woman, okay, who is apparently living in him. And Jane likes to be a mother to everyone, tries to take care of everyone, you know. So these are some examples of dissociative identity personality disorder. Have you guys heard about Dr. Jekyll and Mr. Hyde? Dr. Jekyll and Mr. Hyde. Okay. Okay, you guys have not heard about Dr. Jekyll and Mr. Hyde. It's a very famous literature based on the dissociative personality disorder, dissociative identity personality disorders. Okay, so have you guys understood what dissociative identity disorder is? Dissociative identity disorders. Have you guys understood what dissociative identity disorder is? Okay, so that basically is dissociative identity disorders. So that's that. Okay, good, very good. So dissociative identity disorder, once again, is multiple personalities living in one patient over here, and these personalities, they come out when they want. So this guy could either be John, this guy could either be Eddie, this guy could either be Jane. So that is dissociative personality disorders. Okay, are we clear? Okay, we had a question from Dr. Uday. Let's see what her question was. What's the difference between retrograde amnesia and dissociative amnesia? Okay, what is retrograde amnesia? Retrograde amnesia is basically the inability to remember things before a trauma. Let's say the patient does not remember where the patient was going. Okay. And dissociative amnesia is dissociative amnesia is when the patient forgets who the patient is or who the patient was, the patient's personal information. That is dissociative amnesia. Okay, are we clear about dissociative identity disorder because we want to move on to the next one? Do we have any confusion? Do we have any confusions for dissociative identity disorders? Can you guys hear my voice? Okay, can we move on to the next one? Okay, perfect. Thank you. Okay, thank you for responding. Okay, so the next one is delirium. Okay, what is delirium? Delirium is basically the waxing and waning of consciousness with acute onset, decreased attention, decreased level of arousal. Okay, so what happens is, for example, delirium is basically, let's say that you have a patient who has, let's say that the patient is on high dose, has taken a high dose of benzodiazepine. Okay, so let's say if you take a lot of sedatives, okay, if you take, let's say, 2 sedatives instead of 1, or three sedatives instead of 1, if someone is talking to you, will you be able to pay attention to that person if you are on high sedatives? Yes or no? No. Will you have more attention or less attention? Less attention. Will you be more aroused or less aroused? And by aroused, I mean aware. Okay, that's that. And along with this, is there a possibility you can have visual hallucinations? Yes or no? Yes, you can have visual hallucinations. Uh, can you have decreased intelligence? Okay. Yes. Okay, good. Okay, good. And another thing is, these things can occur in substance abuse. Okay, these things can occur in substance abuse. So what are the substances? For example, if the patients take drugs, for example, benzodiazepines, okay, then alcohol, then what? Then we have marijuana, okay. What else? Marijuana, then opioids, okay, heroin, morphine, these type of things. And along with this, what are some other causes? Infection. Can you expect a patient with meningitis to have delirium? Yes or no? Yes. How about hyponatremia, hypokalemia? Yes. Okay. So these are some of the conditions. These are some of the conditions in which delirium could be present. Okay. Along with this is the patient's mental status. Okay, if the patient has a mental, will the patient have an altered or not altered mental status? Altered mental status. Very good. The patients will have altered mental status. Okay. And how do you treat a patient with delirium? How do you treat a patient with delirium? Okay. Treatment of underlying disorder. So you address the cause. That is correct. So you address the cause. That's what it is. Okay. And at times, antipsychotics could be needed. Okay. But can you give a patient benzodiazepine if the patient is has delirium? No. Can you give the patient opioid if the patient is delirious? No. Okay, good. So that is delirium. Are we clear on delirium? Are we clear on delirium? Okay. Okay. So what you guys can do is you guys can either read the text or you guys can repeat our recordings. Okay, our recordings. You can use it as an audiobook or you can use it however you want. And our recordings would help you identify what the diagnosis is. Okay, what we are talking about. Okay, good. Okay, do you guys want to move forward or do you guys want to stop and start with the UWorld notes? Move forward. Okay. because okay, so the thing is either two things will happen. If we move forward, what we would be doing is we will not be able to do the UWorld notes, but we still will do the UWorld questions. But if we stop here, then we can do the UWorld notes, and it all depends on you. Okay, I have no problem on skipping out on the UWorld notes because we can always finish the UWorld notes later, but I feel like first aid is important to finish, so we could move on with first aid. So what do you guys think? Okay, good. So let's move forward. Let's see how much more we can learn. Okay, so first of all, before we move forward, have we understood everything that we have studied from the beginning till now in psychiatry? Are we doing a good job? Is everything better for you guys? Is anything more confusing? Is there anything? Okay. Have you guys ever tried reading psychiatry by yourself? How? oh, Okay. 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 Reading psychiatry by yourself could be extremely confusing. Okay, so extremely confusing. There could be, okay, you don't know how to recall things. So the thing is, my advice to you is, if you guys want to recall psychiatry, first and foremost, is the lecture helpful or is the lecture confusing you guys more? Okay, good. So that's good to know. So that's good to know. And the thing is, my advice to you guys is, if you want to review psychiatry, okay, my advice to you guys is, especially for psychiatry, I would expect you guys to work together. If you guys can find a teammate in which who will allow you to read psychiatry with you, because psychiatry is less about reading the text. It's more about understanding what the terms are. Okay, so maybe one student can help another student. The way by which is you can paint out a patient scenario and you can ask the student, you can ask your friend what the term is. Let's say you paint out a scenario for the ego defenses, and then you ask your teammate, okay, this is the patient scenario, just as how we do it. What is your diagnosis? And then the patient, and then in the another student can just say it out loud. So that could be a very good and effective way and a fun way of reading psychiatry. So I would suggest you guys do that. Okay. Next one. Okay. Having said that, next one. Next one is psychosis. Okay. Okay. So what is what is psychosis? Psychosis is basically the distorted perception of reality. Okay. Meaning, okay, meaning that let's say that okay, let's say that you have a normal reality in which you are living. Okay, let's say we are all in our room or in our study room right now, am I correct? Or in a library. Okay, there are multiple things which are happening in our environment as of right now, and that could be said as being socially normal or accepted. Am I correct? Yes or no? There are things which is happening around you, which is absolutely normal. Am I correct? Do you have, am I correct? Okay. Let's say you are in your room, you are studying, you are listening to our lectures, and there's no one else in your room, and it's exactly what it is. Okay. If someone has to call out your name, they can call out your name and you can stop the lecture and go and see what's up. Okay. So that is completely normal. Now, what if I tell you that in your room, okay, you are studying and you have someone else standing in front of you? Okay, I do not want to scare you guys. Okay, I do not want to scare any one of you. I don't know what time of the day you are doing the lecture in. Okay, I'm not sure what time of the day you are doing the lectures in, especially for students who are doing the lectures at night. Okay, for 3 a.m.ers or 2 a.m.ers. Okay, so I do not want to scare you guys, but let's say that from a doctor's point of view, okay, from a psychological point of view, let's say you are doing the lecture, okay, and all of a sudden you see a little child standing in front of you. Now, psychologically, is that normal or not normal? Is that normal or not normal? In no way that is normal, okay? In no way that is normal. So the thing is, if those kind of things are happening now, a layman would say, okay, now a layman would say that there's a ghost. Okay, now the layman a person who is not a physician or not scientific or an individual who is well acquainted with science, they would say that it's a ghost or this and that or whatever which they would want to believe. Okay, but if you're a man of science, then you have to understand then that it's a high possibility that these are visual hallucinations. Am I correct? Am I correct? Visual hallucinations. So let's say for some reason you are having visual hallucinations. Okay, so that's one. Another one is, let's say that you are studying in your table. Okay, all of a sudden let's say you have a pen on your table, and all of a sudden you start seeing that pen um, move around like a snake. Okay, move around like a snake on your table. Okay, so the thing is that normal or not normal? Not normal, absolutely, it's not normal. But what happened was you saw the pen move around like a snake, meaning that you had a false perception about an external object. You had a false perception. Okay, it's not an illusion, it's a delusion. It's not an illusion, it's a delusion. Delusion is basically having a false perception of an external object being there. Okay, how many of you guys have gone to the bathroom at night and saw your curtain and felt like someone has been standing over there? I know this happens a lot. Okay. Okay, good. So it has happened to almost everyone. So you go to the bathroom, you see your curtain, you feel like someone's standing over there. Okay. So that's your delusion of an external object. Okay. It's just a delusion. Okay. That's nothing else. Another thing is, another thing is, there's a certain way I am talking to you right now. Is that normal or not normal? Please don't say it's not normal. Okay, so it has to be completely normal the way I'm talking to you right now. Okay, if someone were to say no, it's not normal. Okay, so it's completely normal with the way I am talking to you right now. Okay, right now we are talking about psychiatry. All of a sudden, if I start discussing about, let's say, my family matters to you guys out of nowhere, is that normal or not normal? It's not normal. Why would I start talking about my family matters to my students all of a sudden out of nowhere? So I talked about three things. First of all, I talked about a little child who was standing in front of your computer. That is hallucination. Okay. Then I talked about a pen which you thought was a snake. Okay. So that is delusion. Next one is, I talked about myself, that instead of teaching psychiatry, I started talking about my family problems. That is disorganized speech or thoughts. Okay, so these are the three criteria of psychosis. Are we clear? Are we clear about psychosis? How do you diagnose a psychotic patient? How do you diagnose a psychotic patient? First of all, delusions, hallucinations, and disorganized speech or disorganized thought. Are we clear? Difference between delusion and psychosis. There should not be any difference. Delusion is a component of psychosis. Yes, more or less. More or less, they all stay together at the same time. All three domains, they stay together at the same time in most cases. But even if they are not, let's say you have a patient with only hallucinations, over time, if it's not treated, then they will get delusions, and eventually they will have disorganized speech and disorganized thoughts. So even if they are not together, they will take place together at the same time at one point or another. So okay, so these are the three components. Once again, what are the three components? Because it's really important to identify. Fast answers, please. Number one is fast answers, hallucinations. Then number two, delusions. And number three, very fast answers, please. Number three, disorganized thought or disorganized speech. Okay, good. Now we will talk about delusions. Okay, let's talk a little bit about delusions. So first of all, delusion is basically okay. First of all, there could be a lot of different types of delusions. Okay, there could be a lot of different types of delusions. Okay, basically number one is okay. Number one is, let's say, for example, you have a type of delusion which is known as grandiose delusion. Grandiose delusion. Delusion meaning that yes, they are different. Delirium is basically a medical condition in which the person has if the person is delirious, the person is not aware of the surroundings. Okay, the person has waxing and waning level of consciousness. Okay, and psychosis is completely different. Psychosis have patients who are delusional, who have hallucinations, and who have disorganized speech and disorganized thoughts. So that is psychosis. Okay, so that's that. And delirium is reversible. Psychosis is not reversible. Illusion is something else. Illusion is used by magicians to create an illusion. Delusion is basically your mind saying that something is there on, although there is nothing there. Do you understand? Isn't illusion the one with external stimulus? Okay, so basically what happens is, okay, so let me tell you something. So basically what happens is delusion. Okay, first of all, delusion. Okay, first of all, what is delusion and what is illusion? Okay, so first of all, illusion is, let's say you see an object. Okay, let's say you see an object and that object is shown to you as something, but it's not actually that thing. So illusion is used basically by, let's say, if there's an illusion of magic or like something else. Okay, delusion on the other hand, okay, delusions are two types on broad categories. Okay, two types. One with external stimulus, another without external stimulus. Illusion is always with an external stimulus. Delusion could be with external stimulus or without external stimulus. First of all, you could be delusional to the fact that you can start believing that something is, let's say you are so delusional that you see a pen and you cannot imagine the pen without even seeing the pen as a pen. You start looking at the pen as a snake, as a snake, and no matter how much you want to try, you cannot look away from the snake on your table. But at the end of the day, it's just a pen. Okay, and no one is trying to make that pen look like something to you. This is what you are trying to look. So this is the delusion with external stimulus. Then you have another type of delusion in which the delusions are without external stimulus, and those type of delusions are delusions of grandiose delusions. Then you have jealousy. Then you have persecutory. Okay, then you have somatic. Okay, then you have mixed. Then you have erotomanic. So these are all the types of delusions which are without external stimulus. Am I clear? Is everyone, are we on the same page right now? Okay, are we all on the same page? Okay, good. So right now what we have to do is we have to talk about all the different types of delusions. Okay, right now, but just for the purpose of solving your questions, you won't get a lot of questions regarding all the different types of delusions. Okay, but some are very important. Okay, number one is I want to talk about is grandiose delusion. Does anyone know what grandiose delusion is? Grandiose delusion. Grandiose delusion. What is grandiose delusion? Is grandiose delusion a narcissistic delusion? Yes or no? Narcissistic delusion. It's not narcissism. Okay, it's not narcissism. Narcissism is something else. Have you guys seen President Donald Trump on the news? Okay, yes, he is a narcissist. Okay, so that is narcissism. That is not grandiose delusion. Grandiose delusion, that is not grandiose delusion. Grandiose delusion is a psychosis. Psychosis, basically you believe that you can solve anything. Right now, if you have a patient who comes to you and tells you that, yes, I have found the vaccine for the coronavirus. I have found the vaccine for the coronavirus. I have a friend who works in the White House. Okay, and then when and to be honest, I mean, like he will keep on saying each and everything that will make him feel like he's one of the most important person in the world. And this type of delusion is known as delusion of grandiosity or grandiose delusion. Are we clear? Yes, more or less. Are we clear? Okay. Next one is okay. Okay. Next one. Next one is your persecutory delusions. Okay. So what are persecutory delusions? Okay. So persecutory delusion means that the person will have feelings that the person is being persecuted. So, does anyone know the meaning of the word persecuted? What do you mean by persecuted? What is persecuted? Okay, so basically persecuted delusion in simple words means that a person will tell you that someone is out there to harm him. Okay, so like someone is against them, as simple as that. Okay, so basically if someone comes up to you and tells you that please save me, I'm being followed by these group of people, they're going to kill me, this and this, okay, for no obvious reasons, okay, and they're trying to seek help and this and that, okay, so that is basically persecutory delusion. Are we clear on persecutory delusion? Are we clear? Have you guys understood persecutory delusion? It's very easy to understand. Okay, next one is next one is erotomanic delusion. Erotomanic delusion. Does anyone have any idea what erotomanic delusion is? Okay, so erotomanic delusion. The delusion comes from erotomania, meaning that you have a false belief that you are in love and with the person, with another person, despite the fact that, let's say, that person will claim that he does not even or she does not even know you. Okay, so let's say you have a guy called John who is coming up to you and is telling you that he is insanely in love with his wife called Jane. Okay, and he will describe Jane to you as one of the best women in the world. She can cook, she does this, she does that, and he will even come and tell you where Jane lives. So what happens is next time, let's say you go and you meet this person called Jane and you ask her, okay, hey, how are you? How is your husband, John? And she will reply to you that she has no husband called John. Okay, very scary and very weird. So the delusion that John has that Jane is his wife is known as erotomanic delusion. Are we clear? Are we clear? Erotomanic? Yes or no? Are we clear on erotomanic delusion? Okay, basically meaning that someone will say that someone else is their wife and they will believe it, and in real life it's not true. When you ask the wife will that woman will tell you that she has never gotten married to anyone and she does not know a person called John. So John is the patient over here. John is the one who said that John has a wife, and that's a false delusion. That's a false perception. Okay, that's a false perception. Okay, next one. Next one is somatic delusion. Does anyone have any idea what a somatic delusion is? Okay, so basically, somatic delusion is basically a false belief that one of your bodily function is abnormal. Okay, okay. They believe that patients feel that they are sick. That is called hypochondriacism. Okay, that is hypochondria. So that's not what it is. Basically, what they feel that maybe let's say a patient comes to you and tells you that his hand, let's say he comes and tells you that his hand is one of the strongest hands in the world. his hands can break hammers. Okay, a hand, is it possible for a hand to break a hammer, an iron hammer all by itself? Yes or no? No. Okay, it's absolutely not possible. But the patient will say that it's possible. Okay, so the patient has delusions regarding their hand. The patient, or if the patient comes and tells you that, if the patient comes and tells you that my liver is not okay, okay, and then you ask him why, and then he cannot say why, but he firmly believes that there's something wrong with his liver. Okay, there's something wrong with his liver, and that is a type of somatic delusion. Okay, so he is delusional somatically. Okay, can you repeat erotomanic? Erotomanic is basically a guy coming up to you and telling you that he is in love with his wife called Jane. Okay, this lady called Jane who lives in this street, that street. Okay, and that's his wife. So what happens is when you go and ask that lady that, okay, how are you? How's John? And then that lady will tell you that that she does not have a husband called John. Okay, that she will tell you that she does not even know who John is. So basically, John is that guy who made that story up, and he firmly believes that he has a wife called Jane. Okay, so that is erotomanic delusion. Okay, are we clear on all the different types of delusions? Are we clear on all the different types of delusions? Okay, okay, good. Okay, good. That's your delusions. Okay. Next one is disorganized thought. Okay, what do you mean by disorganized thought? That is, the speech may be incoherent, derailed, or tangential. Okay, if I start talking about, let's say I'm talking about psychiatry, okay, and then all of a sudden I start saying words which have no meaning. Let's say all of a sudden, instead of teaching you guys about disorganized thought, I start saying words like dog, chicken, bird, food, and auto. So, these type of words, this is known as word salad. This is known as a word salad. Word salad is basically you spurting out words which have no meaning, and you are just throwing words at someone for no reason. So this is basically disorganized speech. And derailed speech is basically that example where I started talking about the fact that it would be so abnormal that I started talking about my family matters in front of with you guys for no reason while we were talking about psychiatry. So that is known as derailed speech. So disorganized speech and derailed speech, word salad and derailment. Okay, are we clear about disorganized speech? Yes or no? Okay, good. Okay. Next one are hallucinations. So first and foremost, what is hallucination? Hallucination is basically the perceptions that you have a perception without an external stimulus. Okay, so there is no external stimulus. So once again, you are sitting in front of your computer, you see a young boy running in front of you. Okay, you see a young boy running in front of you. And the thing is, if you see this young boy running in front of you, do you really have anything moving in front of you? Yes or no? Do you have any external stimulus? No, you do not have any external stimulus. It's not like something is trying to be perceived as something else. Okay, this is a completely sole perception with the absence of an external stimulus, and this is known as visual hallucination. So this is known as a hallucination. So they are perceptions in the absence of external stimulus. Now, the first type of hallucination is auditory hallucination. Someone is not talking to you right now, but if you hear something in your ears, let's say you hear that let's say you hear a voice in your head, and it's an active voice asking you to do something. Okay, active voice asking you to do something. What is the type of hallucination? What is this type of hallucination? Fast answers, please. Auditory hallucinations. Okay, these are auditory hallucinations. I'm not sure how much our lecture will scare the students today. Okay, but depending how late it is in the night for you guys. Okay, but hopefully just try to think of this whole thing as a doctor's point of view. Okay, don't try to think about this as a layman. Okay, then you will get scared. Try to think about this from the doctor's point of view, and then everything will start making sense. Okay, next one is our example of a young boy walking or moving in front of you. What is that type of hallucination called? What is that type of hallucination called? Visual hallucination. Next one is if you feel like the young boy comes and jumps on top of you and you feel a skin sensation, tactile sensation. Do you know what the hallucination is? Tactile hallucination. There is a very famous paranoia for tactile hallucination that is known as cocaine crawlies. Okay, people who abuse cocaine, they feel like bugs are running beneath their skin, so they start scratching their skin. Okay, that is known as cocaine bugs. Okay, that is known as cocaine bugs. Okay, next one is, let's say you start smelling something. Let's say you start smelling a food which is not there. It's 3 a.m. at the night and you start smelling pizza out of nowhere. No one is cooking pizza in your house. Okay, and you start smelling pizza at 3 a.m. in the night. Okay, what is this type of hallucination called? Olfactory hallucinations. Very good. Most common reason for olfactory hallucination is a temporal lobe epilepsy. If you have a temporal lobe epilepsy, do you have any idea for which virus can cause temporal lobe epilepsy, or temporal lobe encephalitis, or temporal lobe lesion? HSV. Very good. Okay. Next one is, let's say you not smell the pizza, but you taste the pizza in your mouth, although there is no pizza. Okay, you taste the pizza in your mouth. This is known as gustatory hallucination. Very good. This is known as gustatory hallucination. Okay, so that is that. And okay, another one is if you feel like you are going to sleep. Okay, let's say that there's a type of hallucination which occurs when you're going to sleep, while you're going to sleep. Okay, so this is known as hypnagogic or hypnagogic hallucination. Another one is a hallucination which you feel after you wake up from the sleep. This is known as hypnopompic. Okay, let me write it down. Hypnagogic and hypnopompic. Okay, are tumors associated with hallucination? Yes, tumors are associated with hallucinations. Okay, that's that. Okay, hypnagogic and hypnopompic. Hallucinations while you're going to bed. Hypnagogic gogic for going to bed, and hypnopompic meaning you're pumped up after you wake up from your sleep. So hypnopumping. Okay, so hallucinations after waking up, hypnopompic, while going to bed, hypnagogic. Okay, are we clear? Okay. Okay, it's 1:43 as of right now. Okay, do you guys want to continue the lectures more, or do you guys want to stop here and we can start from tomorrow? Okay. Okay, I feel like too much information will crowd your brain. Okay, so okay, we have studied a lot for today. Okay, we have studied a lot for today, and okay, we will stop. We will stop. Okay, so we have students who are saying, "Stop, please stop." Okay, I swear I will not make you guys study a single page. Okay, so that's that. Okay, so okay. GIT and CVS lecture recordings. Dr. Harry, we were trying our best to find some recordings, but I'm not sure if we mentioned this before, but some of our recordings have crashed. Okay, we apologize, but we said this message, some of our recordings have crashed. So what we said was, even if you have problems with understanding, what you can do is send out an email for the topics which you find difficult, and we will take extra classes at the end of the lecture to talk about those things, so that none of the students have problem in understanding any of the text previously read in first aid. Okay. 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 All right. So that's that. Okay. Now that being said, is gustatory hallucination, meaning the ability to taste something which is not there. Okay. Hallucinations about taste. Okay. Okay. So now the thing is, okay. So the thing is now we will be doing our UWorld questions. Okay, that's what we will be doing. And having said that, for all the students who have joined the lecture for today and who have not completed their transactions and have not sent out emails for extensions, okay, for who have not sent out emails for extensions, nor have they finished the transactions. So the thing is, for those students, we will assume that they do not want to continue with us in the future. And unfortunately, if that's what it is, then we will fail to provide the Zoom URL link with those students. Okay, so the thing is, if you need extension, please let us know so that we can provide the Zoom links to you guys. Okay, you guys can take extensions. That's not a problem. Okay, we know that there are certain obstacles and difficulties that comes while making a transaction, but if we do not receive any email for extension, what we will be doing is we would be assuming that the student does not want to continue with us, and we would stop sending the lectures and the Zoom URLs. Okay, so please, if you need to complete your transactions, make sure you complete it by today. Or if you want, if you need extensions, please let us know so that we can provide you the necessary extensions you need to complete the transactions later. Okay, having said that, can we take 5 minutes to gather URL questions? Adenom, yes, Dr. Adenom, what is your question? How's reality test intact in depersonalization? Okay. Okay. So, okay. Okay. If you have a person, Dr. Adenom, can you unmute yourself? Can you unmute yourself? Let's see where you
Yeah,
are.
yes, doctor.
Okay, perfect. Dr. Adenom, the question which you have asked is a very good question. First of all, let me thank you for asking. So the question from Dr. Adenom was, how can I understand that the reality test is intact in depersonalization? Okay, if you have a patient with depersonalization and you, let's say, ask the patient to tell you if a pen looks like a pen, will the patient who has depersonalization tell you the pen looks like a pen, or will he tell you that the pen looks like a snake?
He would tell me it looks like a pen.
He will tell you the pen looks like a pen. Very good answer. So that is intact reality. But if you ask a psychotic patient, what does the pen look like to you?
Yeah.
Is there a possibility the psychotic patient can tell you that the pen looks like a snake? Yes or no?
No.
Yes, there is a possibility. The patient who has psychosis, to him, the pen can look like a snake, right? Because due to
Yeah.
Okay, so is the reality intact in psychosis?
In psychosis, it is not intact.
Not intact. Very good. But
Yeah.
if in a patient who has depersonalization, is the reality intact in a patient with depersonalization? Yes or no?
It should be, yeah.
Yes,
my question is, doctor, for example, the concept of derealization.
Right.
He does not, he is detached from one's environment.
Yeah. He is detached from his environment, but that does not mean that he's psychotic. Do you understand what I mean?
Yes. I don't get the meaning of derealizing his environment.
Okay, meaning that, let's say, okay, let's say that you have a patient who comes to you and who tells you that, Dr. Adenom, when I go to sleep, what happens is I see myself lying down on the bed, sleeping, and I am completely unaware of my environment, meaning that I have no clue how I feel. All I feel is I see myself lying down on the bed. I see myself lying down on the bed. I'm completely unaware of my feelings. I'm completely unaware of my touch, about how I sleep and this and that. So right now in that patient, this type of complaints are known as depersonalization complaints or derealization complaints, meaning that the patient it has a false perception of the action or the environment. At this point, if you ask this patient, a question to see whether his psychology is intact or not. If you ask this patient that, okay, can you tell me how this pen or how this object looks like to you? And if that object is a pen, the patient with depersonalization disorder will tell you that it's a pen. Okay. And that means the patient has intact reality. The patient has no problem with understanding the reality. The patient is just dissociated from the reality. But if you have a patient who is psychotic, okay, and you ask the patient, how does this pen look like to you? And if the patient is psychotic, then the patient obviously has hallucinations. And visual, if he has visual hallucinations, then that pen will look like a snake to him.
Thank you, doctor. Yeah, good.
Okay, you are absolutely welcome, and a very good question. Okay, do we have any other question from any student? Is it like he sees his own room strange? Yes, more or less. Okay, you know what, let me show you guys a picture. Since you guys are having so much problem with depersonalization, do we have any students over here who are fans of the series Supernatural? Anyone? Okay, anyone? Okay, good. Dr. Hassan. Okay, Supernatural. Okay, so I'm a huge movie and TV buff. Okay, that's all I love to do: watch movies and watch TV shows. That's what I do in my free time. So I use a lot of TV and movie examples. Okay, so Dean Winchester, that is correct, from Supernatural. Okay, okay. So what happened is, okay, let's see. Let's see if there's a proper image. Okay, there was this one image where, okay, wait. Okay. Okay, how does this image look like to you? This is the patient. Okay, and this is you. Okay, let's say this is you with the disorder. This is how it looks like to the patient. This is the patient's eyes. The patient can see the patient sitting on the sofa. He can literally see himself. He's dissociated from his own body. Okay, this is known as depersonalization. Okay, this is known as depersonalization. I used the example of Supernatural because there was an episode in Supernatural where, well, one of the characters was depersonalized after he died. So that's what it is. Does this picture make sense to you guys? A very good picture. Okay, this is a very good picture. Okay, this is the patient's eyes. This is how the patient looks like. The patient is sitting on the chair, but the patient is dissociated. So the patient is looking at himself. Okay. Okay. Okay, having said that, can we take that 5 minutes break to make the questions? Okay. Okay, perfect. Okay, let's take that 5 minute break and we can come back and solve the questions. Okay, can everyone hear my voice? Is everyone back from the break? Is everyone back from the break? Can you guys hear my voice? Are you guys back from the break? Okay. Has it been 5 minutes already? 1:54. Yes, it's exactly been 5 minutes. Okay, so we have the questions ready from behavioral science. Okay, so uh, what we would be doing is we would be also trying to solve some ethical questions. So questions regarding ethics. Okay, so medical ethics, and these are basically these are the answers which you have to which you have to basically figure out from UWorld, because they do not have it completely broken and written down in first aid. Okay, but these are very easy, and I will tell you exactly what to do. Okay, so the easiest things to answer about medical ethics is to go for the answer options, which is the least harmful to the patient, or which respects the patient's autonomy. Does anyone know what autonomy is? What is autonomy? Autonomy. Does anyone know the meaning of the word autonomy? Autonomy is basically the ability of the patient to make decisions for himself. Okay, to make decisions for himself. So the patient's autonomy has to be respected. Okay, so over here, the patient's autonomy has to be respected. So no matter what, if the patient does not want a treatment, you cannot provide that treatment. If the patient does not want a procedure, you cannot provide that procedure. The patient needs proper counseling before the patient can agree to a procedure, and that is up to you, but you cannot force anything down on the patient as long as the patient has an intact autonomy. Okay, so that's what it is. Okay, having said that, are you guys ready to begin the questions? Yes or no? Okay, so what I would be doing is I would not be coming back to this chat box anymore. Okay, so if there's anyone who is wanting to enter the lecture, please let me know if you view it. And what we will be doing is we will be going straight to the questions, and we will be discussing it from there. Okay, so just tell me the answer when I ask you. Okay, so this is the first question. Okay. Okay, so can everyone hear my voice? Yes or no? Yes, so can everyone hear my voice? You guys can unmute yourselves.
Yes, we can hear you.
Perfect. Okay.
Yes, dear.
Okay, good. So when we read a question, the first thing that we have to read is the last line. So the last line is, which of the following is the best next step in the management of this patient? We're talking about the management, so we'll read everything over here. From what it looks like, this could be our answer, but let's see what's going on. Okay. A 6-year-old child is examined in the emergency room and found to have a well-demarcated round burn mark on his thigh. When asked about the burn, he says that happens every time I'm bad. Okay. The round burn mark on his thigh, what does it represent?
Abuse.
Abuse.
Of course, it represents
Abuse.
abuse. But what is the round burn mark on his thigh? Does anyone have any idea? What is this burn mark from?
Maybe like a cigarette burn.
Cigarette burn. There we go. It's a cigarette burn.
Yeah.
Okay, we have a lot of abusive parents who smoke. Okay, and then if the child is, if since they are mentally not sound, okay, they're mentally not sound. So what they do is they stab the, they stab the cigarette on the child's thigh. So that's basically what they do. Sounds horrible. So what is your next step? What is the diagnosis?
A.
A.
Very
A.
okay.
Child protection.
Okay, very
Child
easy.
protection.
Very. Okay, good. Next one. Okay, this is a big one.
Oh my
Okay. Oh my God, oh, I know. Okay, but there's nothing you can do. There are questions which will come like this in your exam, and you have only 90 seconds. 90 seconds, okay? So easiest way to read this. What is the first thing you have to read? The last line. What is the best course of action? Okay, they're asking for the course of action. These are all actions. Okay, now let's start. You are caring for numerous patients on a busy hospital at a regional Veterans Administration hospital, meaning that the hospital for war veterans or army personnel. Okay, you were called at 3 o'clock in the morning by nursing staff who state that one of your patients who was admitted for chest pain is suffering from acute onset watery diarrhea. So this is, you underline this. When you go to see the patient, he states that all of this began a few hours after he drank a big jug of clear water stuff. Underline this, that the nurses gave to him. In reviewing his chart, you find that you accidentally prescribed an electrolyte bowel preparation with chest pain rather than for the intended patient with the GI bleed who is scheduled for a colonoscopy. Okay, so it should have been something else. It should have been an enema, but instead, what you gave was you gave a bowel preparation. So that's the thing. Now the patient states that he feels so good because he had not had a bowel movement in the last 2 days. What is the best course of action? Okay. A, you immediately inform the patient that you mistakenly ordered a bowel prep. B, you call the risk management and ask for advice on whether to inform the patient. C, no need to tell the patient. D, ethics committee must be consulted. E is inform the patient of the error and offer to compensate him financially, means that you give him money. Okay.
No, A.
B.
A.
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 Which one?
A.
A.
Okay. How many of the students said B right now? Do we have
Me.
it? B. Why would you call? Why would you say B? Why would you say? Okay, so the B is immediately call risk management and ask for advice on whether to inform the patient of this error. Okay. First of all, is this your mistake or not your mistake? I mean, you as the physician, like the
Yeah,
physician. You were supposed to give him something else, but you gave him and bowel prep. So is it not important that for a physician you have a strong ethics, that you stand up to your mistakes and then you accept your mistakes? Is it important? Yes or no?
Yes. Yes. Yes.
So if, as your patient, does the patient not have the right to know about your mistakes?
Yes.
Yeah.
Right.
Okay. Yes. So do you immediately inform the patient about your mistake and explain, or do you not do that?
Yes.
Okay. Yes. So now what is your answer?
A.
A. The answer is A. Okay. The answer is A. The answer is not B. You do not call risk management. Why do you not call risk management? Because you are a resident physician. You are your own boss. Not really. I mean, like you have to report to supervisors, but obviously you will not call the risk management and ask for advice because there's no way they can help you. Okay. You have to stand up for your own mistakes. So B is out of the question.
But doctor,
C, yes.
I could think about C because there is no already damage. Like the patient is not complaining to you already.
Sure, there is no problem, but there is not. But the thing is, okay, let's say you are a resident and internal medicine resident doing his rotations in gastroenterology. Okay, right now, if your supervisor who is a gastroenterologist, he sees the treatment sheet, and if he asks you that okay, who was the doctor who just said he wanted to have C, who wanted to answer C? Was it Dr. Hassam?
Yeah.
Okay, Dr. Hassam. Now, if your gastroenterologist came up to you and tell you that, okay, Dr. Hassam, you are not supposed to give electrolyte bowel prep, but you have given the patient electrolyte bowel prep, have you done the right job or the wrong job? What will be your answer?
Yeah, I will tell him wrong.
Wrong job. Okay, I have done the wrong job. Although the patient was benefited, but we had no idea that the patient was constipated. We did not know. The patient could not have been constipated. The patient could have been dehydrated for all you know, right? So, so it was a mistake on the doctor's end. So the doctor has to immediately own up to the mistake and order a bowel preparation for him. I mean that you mistakenly ordered a bowel prep for him and explain what happened. So A is the right answer. Okay, D is the ethics committee must be consulted. Okay, always remember whenever you see ethics committee, that this is never your answer. Okay, this is one thing which I can say for sure. In most cases, I only received one question in AMBOSS where the ethics committee answer was right. Although still I have my confusions regarding that question, but whenever you see the ethics committee being involved in a question regarding medical ethics, okay, that is never your answer. Okay, so this is an easy no. Okay, so D is never your answer. E is inform the patient of the error and offer to compensate him. For obvious reasons, I'm sure none of you will offer money to the patient. So E is not your right answer. Okay, good. So that's that. Okay, next one. Next one is, okay. Okay. Let's read the last line first. Which of the following is the most appropriate response to the patient's request for tubal ligation? Okay. So a 30-year-old woman comes to the gyno for an annual physical examination. The patient is in good health and does not report any symptoms. Okay, none of these are important. During the visit, she says she would like to go BTL. Okay, so you underline this bilateral tubal ligation. She is tired of using OCP and does not wish to have children. She has had no side effects to OCP. The patient has been married for 10 years and describes the relationship as very stable. Okay, so these are not important. Only thing is she wants a bilateral tubal ligation and her age is 30. Which of the following is the most appropriate response to the patient's request? Okay, let's go. So let's read the answers. And what is the right answer?
E.
A.
E.
Confirm for the patient.
E.
Does anyone else have any other suggestion?
E.
Okay. First and foremost, the first thing which I said about medical ethical question is two things. Number one, patient benefit, and number two is patient autonomy. Okay, so patient can decide whatever the patient can do. Okay, so first of all, what is your duty as a doctor? Your duty as a doctor is you have to tell the patient about the risks and benefits of the procedure, and the rest is on her. Okay, so the correct answer is E. Okay, the correct answer is E. First of all, you have to review the risks and benefits of the tubal ligations and alternate birth control methods. Okay, why is this not A? Confirm that the patient has discussed the decision with her spouse. It is not appropriate at all. Okay, because the patient is solely the patient itself. The patient can do whatever the patient wants to do, regardless of what her husband thinks. Okay, so this is absolutely not the right answer. Confirm the patient's spouse agrees with her decision. Once again, okay, this is not Bangladesh. Okay, where we grew up. Okay, so that's where I'm from. I'm from Bangladesh myself. Okay, over there, patients' autonomy was not respected as much. Okay, there were times when the husband would speak over the wife. Okay, and I have personally seen cases like that. Over here, that is something which you cannot tolerate. Okay, which will not be tolerated, and the patient spouse has nothing to do with the patient's decisions. So B is the right answer. C, encourage the patient to consider deferring the procedure. She is young and may change her mind. That is you as a doctor trying to disrespect the patient's autonomy. So this is C. C is not correct either. D is inform the patient that the procedure requires her partner's consent. Tubal ligation does not require the partner's consent, nor does a vasectomy. If it's a male patient who wants to perform a vasectomy, the patient does not need the spouse's consent. Okay, so that's that. Are we clear on these questions?
Yes.
Okay,
Yes.
the reason why I'm taking my time to answer each and every question is because medical ethics have to be understood, and understood why the answer is not right, why the answer is wrong. Okay, why the wrong answer is wrong. Okay, having said that, let's move on. Okay, two more questions, guys. We're very close towards the end. Okay. Okay. Okay, which of the following is the most appropriate course of action? Okay, the sports physician for a college football team is asked to assess the team's starting quarterback for complaints of fever, sore throat, and malaise. Okay, so underline this. His temperature is 103, underline this. Blood pressure is 120/80. Pulse is 90, respirations are 14. Physical examination reviews tonsillar exudates, cervical lymphadenopathy, splenomegaly. Okay, underline all of this, very important. Blood smear shows atypical lymphocytosis with a heterophil monospot test negative. What is the diagnosis of this patient? Can anyone tell me?
Mono.
Okay, so someone said mono, so that is correct.
EBV.
Oh,
Mono.
Infectious mononucleosis.
that's the same thing, infectious mononucleosis.
Yeah,
Okay.
same.
While educating the patient about his condition, the physician explains that he should not play contact sports. Why should this patient not play contact sports?
Rupture of the
Splenomegaly.
Sorry, it says over here. Okay. A risk of a potentially life-threatening splenic rupture. So that's what it says, because patients have splenomegaly. The patient begs the physician not to tell his coach. He explains that the team and the coaches are counting on him, blah, blah, blah. Which of the following is the most appropriate course of action? What will you do as a physician?
Is it E?
Okay.
E?
Does anyone else have any other suggestions?
D.
And then the patient be restricted from plan.
Okay, this is a very good question. This is a very good question, and the
Is it
person.
D.
D. It's D.
But then what about the patient's autonomy?
Oh.
The
No,
patient is harming himself, the physician.
it would be very destructive for the patient.
Okay, good. Okay, so what is autonomy? First and foremost, autonomy is the patient's right to make the decision for themselves when it comes to a procedure. Okay, let's say you have a cancer patient of the thyroid. Okay, the patient, what is the surgical operation the patient needs? Last answers, please.
Thyroidectomy.
Thyroidectomy, right? If the patient comes and tells you that I do not want a thyroidectomy, can you perform the thyroidectomy? Yes or no?
No.
No, that is you
No.
respecting the patient's autonomy. That's it. That is
Immediate
you.
informed consent.
But over here, what's happening is this patient over here is not making the right decision for himself in the sense that he is trying to, let's say that, you know, like I mean, the doctor knows that if he tries to go and play football, obviously there will be contact with splenic rupture and the patient will obviously die. So it's the duty of the doctor to let the coach know. That's the duty. After that, if the coach lets him play, that's on the coach. That's not on him. Do you understand? So that's that. So over here, if it was a procedure, let's say the patient needed some sort of a splenic surgery, and the patient said, "I will not do the surgery." The doctor cannot make the patient do the surgery. Okay, so but the doctor has the right to let the authority know that the patient is in the means of harming himself. So that's what it is. Okay, so the correct answer is D. Okay, the first answer, allow the patient to participate to increase his chances of playing professionally. Absolutely incorrect. Okay. B, allow the patient to play as it is in the team's best interest. Okay, the doctor does not care about the team. So B is not the right answer. Do not inform the coach of the player's condition, as this would violate the patient's privacy. This is not violating the patient's privacy. The privacy will not be violated unless the patient is in the right mind to make the decision. Okay, good. Okay, so we have a breather. Okay, who's breathing so loud over here? Okay, now we do not have any breathing. Okay, no problem. I have no problem with you breathing. Okay.
Osa.
Okay, next one. Okay, this is a difficult one. We have not discussed these things before. Okay, so I would highly appreciate if anyone can answer this even out of chance. That could be good, but this is actually pretty easy to understand. Let's read this through. The last question is, which of the following is the appropriate categorization for this type of medical error? So there are some medical errors which we will talk about in the future. We have not talked about them yet. Okay, so what's the error? A 46-year-old woman is hospitalized due to severe depression and fatigue. She has no other medical problem. Routine laboratory tests are ordered and the patient is started on antidepressant. After a week, her depression improves and she is discharged from home to continue with outpatient care. Okay, so what's going on over here? None of this has been an error, so none of this is important. So keep on reading. However, the patient remains severely fatigued and is unable to return to her job, forcing her to take a leave of absence. At her following appointment 2 weeks later, review of the hospital record by the outpatient physician reveals a TSH level of 15.2 that was never addressed by the inpatient physician. Now, this is high yield, so you underline this. The fact that the patient's, first and foremost, if you have a patient with hypothyroidism, does hypothyroidism affect your mood? Yes or no?
Yes.
If you have a patient who comes to your clinic with mood problems, and if it's a patient, you see that she has constipation, she's a bit overweight, or he is a bit overweight, okay, or he or she has a deep voice, hoarse voice, will you consider TSH or not?
Yes.
Yeah.
Yes, so you will. So if you fail to address the hypothyroid level, that's an error on your part. Okay. Now the next question is, what is the appropriate categorization for this type of medical error? Okay. Now
B, near miss.
Never miss.
Near miss. Yeah.
Okay. Who else?
Near miss.
D.
First of all, is this an adverse event or is this not an adverse event? The patient
Misdiagnosis.
No, this is not adverse.
No. Hear this out. What happened was, since this patient has hypothyroidism for so long, the patient could not, if the patient was treated, If the patient was treated for hypothyroidism, will the patient have depression or no depression?
No,
No
No
depression.
depression.
Very good, because her depression is related to her thyroid problems. So right now, the fact that the patient has the depression, is that an adverse problem or not an adverse problem? It is an adverse problem. It's something which should not have happened, but it did happen. So it's an adverse event. Now the thing is could you have prevented this or not prevented this as a physician?
Yes, you could have.
Yeah.
Prevented.
If
Yes.
you wanted to, if you paid more attention at your job, if you did your job right and you did all the routine medical examinations, then, and if you addressed all her signs symptoms accordingly, then you would not have missed out on the fact that this patient
So,
has
he's waiting outside. He's waiting inside, ma'am.
who?
Yeah. Yeah.
Are you
I
okay?
think she's talking with someone
Oh, you're
near.
talking to someone else. Okay, perfect. You're talking to someone else, because I started thinking you started addressing me as ma'am. I got very worried over here. I was very worried. Okay, that's what it is. Okay, so the main answer is preventable adverse event. So this is something which you could have prevented if you were doing your job right. Okay. With that being said,
But
yes.
one question, but like the patient could sue me, and then will it be not a case of malpractice? Like that was like, I mean.
Okay, but that's
mean,
a
it's
different question. No, sure, but that's a different question. Okay, so that's a different question. So what would happen is if you have preventable adverse event, okay, if the patient won, then the patient can take legal action against you. Okay, that is something, but that's a different question by itself. But first of all, your medical error has to be categorized, because to be honest, if you do a malpractice, then the punishment is of one type. If it's a preventable adverse event, then the punishment is of another type. Do you understand? So
Yes.
if it's a malpractice, then your punishment will be more. Do you understand?
Mhm.
If it's a preventable adverse event, then maybe
I have
your
a question.
Yes, what is your question?
For the near miss event, is it like, how would you distinguish that with the other stuff? Is it because in near miss you're able to catch your mistake before it leaves?
Right, yes, exactly. So a near miss is basically a medical error in which the error is recognized before the harm is done to the patient. Do you understand?
Okay.
So let's say an example of near miss. Okay, so the near miss is, let's say you prescribe the patient methimazole. Okay, let's say you prescribe the patient methimazole, but then let's say you write methimazole in such a way, or there's a typing error in which the pharmacist tries to give out some other drug to the patient, right? But before the pharmacist could even do that, you address the problem and you call the pharmacy and you tell them that the actual drug is methimazole and not any other drug. So so you prevent the problem before the harm is done to the patient. So that's a near event.
Okay. So you caught it before it happened.
Right, perfect. So that is a near event. The next one I want to talk about is sentinel event. So what is basically a sentinel event? This is basically an unexpected occurrence. Okay, this is basically an unexpected occurrence which can involve either death or a serious physical or psychological injury that would result in an immediate police investigation. Okay, so with that being said, basically, sentinel event is basically, let's say that someone is highly allergic to penicillin. Okay, we have those penicillin allergic patients. Right now, what happened is you prescribed penicillin to this patient without even considering that patients can be allergic to penicillin. So what this did was, okay, so what this did was this sent your patient to a widespread anaphylactic shock and the patient died. Okay, that's one type of example. Another one is, let's say let's say there has to be an amputation of the right leg of the patient due to necrotizing fasciitis. Okay, and what happens is, instead of amputating the right leg, you amputate the left leg. Okay, that is also a sentinel event. So this requires immediate investigations, and the scariest part is the doctors will 100% lose their medical license. Okay, so all the things that you have worked for so long, USMLE step 1, step 2, step 3, residency, fellowship, everything will get canceled and you will come to becoming, you will become zero. Okay, so that's what it is. Okay, very scary. So we also, as a physician, it's our duty to be very, very aware of what's going on. Okay, because do no harm, right? If you can't do anything, at least don't do any harm. Okay, refer the patient to someone else who will do a better job. Okay, so with that being said, are we on the same page? Did everyone understand all the explanation for the 5 medical ethical questions?
Yes.
Okay,
Yes.
okay, so things to learn is do no harm. Okay, so thank you so much for doing the lecture for with us today. I'm going to unmute you all, and with that being said, this has been a very long lecture. Okay, so we did the lecture for more than 5 hours, five and a half hours. Okay, you guys can take a small break right now and then do the UWorld questions. Okay, I took my time with the psychiatry portions. I hope you guys do not mind. Or thank you guys for having your patience. The reason is because I want to make sure that you guys have understood all the terms. And if I'm not satisfied, then I do not really move forward. Okay, so that's what it is. So before you get satisfied with me, I have to get satisfied with my own teaching. So I keep on reading the same thing over and over and over again so that you guys can understand. Okay, so that's good. So even if it's taking us a bit more time, always remember that the quality of our study is better than the quantity. So that's what it is. And having said that, we will meet each. We will be here for tomorrow. Okay. So the thing is, for tomorrow, is it okay if we start the lecture a little bit late because there's a doctor's appointment, tele doctor's appointment for my father, which I have to be present with. It starts at 9. Hopefully, it will end by 9:30. So if we start at 9:05, that okay? Okay. So tomorrow we'll start at 9:30 to 9:45. That's what we'll do. Okay. So it's only for tomorrow. And what we once that would happen, we will try to make it up later by doing extra 1 hour classes. So no classes will, no hour will get missed. You guys will be, okay. That's what it is. Okay. Can we have the physio access? Okay, so that's a very good question. So the access for the physio, what I would do is today I would send you guys. Okay, so I will send you guys the names. So we have 33 students more or less who are doing the classes with us. Okay, so, so we have to make sure that each and every one of you guys, each and every one of you guys gets access to Dr. Najib and physio. So what we would do is we would choose 5 students each week for Dr. Najib and 5 students each week for physio. Okay. For this week, what we would be doing is we would be choosing the students who would share the Dr. Najib links. Okay. And what they will do is they will download the videos and they will have to communicate in between each other to see who can access first. Because the thing is, if you sign in with the email address and the password, and if another person signs in at the same time, then you guys cannot be using the website at the same time. So you guys have to make sure. Okay, so you guys have to make sure that you guys are using it at different times. Okay, so that's that. Okay, so the thing is, I will send out the email address and the password for Dr. Najib to the 5 students, and you guys can use it for this week and next week. You guys, and the next week, what we will do is we will choose another 5 students who will use it. So eventually, what would happen is everyone can use the Dr. Najib every month. Okay. Next one is the one for physio. Physio is basically 5 students who will get Dr. Najib, and the other 5 students will get access to physio. And physio is another one thing where the same rules have to be applied. That is, if you are watching physio, then you have to inform your friends that they can watch the physio tomorrow, so that way we can all use it. And that's that. Okay, so that's what we will do, and that's how we will use the subscriptions. Okay, having said that, do we have any more questions? Because it's pretty late, and if not, then I would like to take my leave. For the students doing classes late at night, 1:30, 3, we really appreciate you guys doing the classes so late at night. Okay, hope you guys exceptionally well in your step 1. Okay, good. Okay, great. So no more questions. If you guys have any questions, please send us an email and we will try to answer it for you. Hope you guys have a nice day too. And that's that. Okay, so see you guys tomorrow at 9:30, 9:45. Okay, have a great day. Bye-bye.